Thank you for coming, especially after lunch. Today we have a great session. It's, I would call a united. Okay. I call a United Nation session because there are people from many countries in the world. So the first speaker, so I share the session with my friend Gordon Rubenfeld from Toronto, and I am Jesus Villar from Spain. And the first lecture, the first speaker is Marco Ranieri from Bologna, Italy. He is going to talk about, it's a question, it's a question mark, is there ARDS without mechanical ventilation? We will know at the end of his lecture. You have 15 minutes, no more.
I will
Marco.
speak less. I will actually speak less, try at least. Okay, thank you very much. This is the Berlin definition. Gordon and I and many others probably around here were involved. And in the Berlin definition, we allowed for patients with mild ARDS to have CPAP higher than 5 centimeters of water pressure, implying that for mild ARDS, spontaneous ventilation supported by CPAP or non-invasive ventilation, and the wordings were not exactly straightforward. Now, Gordon says that is my problem with the English language. I said it was Gordon's problem because of his confusion at the moment we wrote the text of the Berlin definition. But there is certainly a confusion about the fact that patients without invasive mechanical ventilation can or cannot be classified as having ARDS. And this is not a new question, because since many years, especially Michael Mathey group was questioning if a patient without ventilatory support could or could not be classified as having ARDS or not. Now, let me make one point clear as much as possible. Of course, you have ARDS regardless the fact that you are on mechanical ventilation or without mechanical ventilation. But the problem is that it's hard to classify, especially because the number of variables that we use to identify patients as having or not having ARDS is linked to the level of support. The PEEP ratio is one of the markers of ARDS, depends pretty much on the level of PEEP, on the fact that the patient is ventilated or not. But of course, the disease is taking place regardless the disease. The ARDS is not a disease. The underlying biological process that is leading to ARDS is taking place regardless the fact you are on mechanical ventilation or not. So, having said that, several authors proposed a number of tools to assess the potential risk for developing ARDS on spontaneous breathing. This is one of the first studies that was able to propose a tool that was able to identify those patients with a high level of sensitivity and specificity. Later on, this paper from Thiel group proposed that patients on oxygen fulfilling criteria for others criteria for ARDS, so PF on spontaneous breathing, X-ray, and underlying disease responsible for ARDS is classified as having ARDS on spontaneous breathing, had the same mortality as reported for lung safe or for the Berlin definition. And this is a later study from Michael Mathey and Caroline Calfee that show that patients that were never intubated with severe hypoxemia that could have been classified as ARDS regardless of mechanical ventilation, and patients that had early intubations in the ICU had a similar mortality, leading to the concept that spontaneous breathing subject fulfilling the other criteria for the ARDS could be classified as having ARDS. Now, then, we all experienced the COVID-19 when many of these patients were treated with high-flow nasal oxygen. Now, those patients were classified as having by ARDS, but strictly speaking, the Berlin definition criteria would not allow them to be identified as having ARDS. And because of this, Michael Mathey, Taylor Thompson, and Lauren Ware wrote this very nice piece published on the Lancet Respiratory Medicine, suggesting that among a number of elements that should be included into an expanded definition of ARDS, the use of high-flow nasal oxygen should have been considered as equal to mechanical ventilation in order to classify patients with ARDS. After that paper was published, we thought that we might have the right numbers to investigate retrospectively the statement made by Michael Mathey. So we took a number of studies that were run during the COVID-19 that we performed in Italy. So it's one randomized controlled trial and two retrospective studies and one prospective study. And we selected patients that matched all criteria for ARDS and that were treated exclusively with high-flow nasal oxygen or non-invasive ventilation. And we were able to see that if you take the PF ratio criteria, again, those patients had bilateral infiltrates, PF ratio lower than 300, but could not be classified as having ARDS because they were treated with high-flow nasal oxygen. So we took them at the entry in those studies, and we could see that almost all of them matched the PF criteria for ARDS. Then a number of them were intubated, and as you can see, for the patients treated with high-flow nasal oxygen, the PF criteria was matched for almost all of them. Of course, before intubation, you see a very narrow distribution of the data points. After intubation, you see a scatter of the points. So, of course, after intubation, the severity of ARDS, as assessed as the PF ratio, changed. But almost all of them matched the PF criteria for the ARDS. So you could, in theory, say that allowing high-flow nasal oxygen to identify patients with ARDS is as good as conventional invasive mechanical ventilation. And the same picture was true for non-invasive ventilation. Now, however, if you look at mortality, you can see that the mortality in the subset of patients that were exclusively treated with high-flow nasal oxygen was about 5%. The mortality rate in the patients that were transitioned from high flow to invasive mechanical ventilation was about 28–30%. And the same picture applied for non-invasive ventilation. So you would say, what's the problem here? The problem is if you say, I allow patients on high-flow nasal oxygen to be defined as ARDS, and you include these patients in a randomized controlled trial, you are including at that data time point, patients are going to have a very different mortality, because the patients that will remain on high-flow nasal oxygen will have a very low mortality, while patients that will evolve towards a more invasive, a more complex level of ventilatory assistance, such as invasive ventilation, will have a much higher mortality. And a few months later, this study from Uppsala in Sweden showed consistently result. And again, that high flow was associated with lower PF ratio than either non-invasive ventilation or mechanical ventilation. Again, raising the point that the variability of the PF ratio, the dependency of PF ratio based on the level of ventilatory assistance that you are applying can make problematic the definition, the inclusion in the Berlin definition. I'm not saying that defining ARDS. We took a step further, and I'm presenting you preliminary data unpublished, where we didn't look just on patients on high flow. These are patients that were admitted at the emergency room, and they had a PF ratio lower than 300, matching the ARDS criteria of the Berlin definition, so chest X-ray and underlying disease responsible for ARDS. And we follow those patients when they were on non-invasive ventilation in the respiratory unit or when they were intubated in the ICU. And again, as you see, if you focus on PF, you still remain in the range of the Berlin definition of ARDS. But if you look at mortality, patients that remain on conventional oxygen or patients that were treated with non-invasive ventilation ranging from high-flow CPAP to non-invasive ventilation in the medical ward remain relatively low as compared to patients that transition to invasive ventilation. So based on this, and you see, I promise you I'm staying on time, revising the Berlin definition criteria to allow inclusion of patients while on high-flow nasal oxygen, of course, may allow early identification of these patients for future randomized controlled trial. But it will introduce a substantial bias in terms of expected mortality, so may be problematic in designing clinical trials using these criteria. So we need to agree on what we consider ARDS. It's either an expanded definition, it's either a change in the approach to the definition process of a syndrome such as ARDS, but for sure we cannot limit the solution of these problems to an expanded definition of ARDS. Thank you very much.
I think it's time for 100 questions because...
I thought I was doing the questions.
You know, but for 100 I said because he already...
Are there any questions from the audience? Does anybody want my co-chair? Are there any? Because I have one. No? Dr. Ranieri, has anyone looked at it strikes me the chest x-ray is going to be affected by whether the patient is intubated, and we have enough trouble with the x-ray, but now you're talking about patients that are spontaneously ventilated and tachypnic, and the likelihood of getting a chest x-ray that's basically an expiratory chest x-ray to assess for the magical bilateral infiltrates compatible. So yes, the oxygenation criteria may remain the same, but has anybody assessed the now expiratory or likely to be expiratory chest x-rays with crowded vasculatures, et cetera? Has that issue been looked at versus spontaneously ventilated versus intubated?
I don't think anybody has looked systematically at this aspect. I mean, if you want to use a standard chest X-ray to classify a spontaneously breathing patient as having ARDS according to the description that we provided in the Berlin definition, actually, I think it's a very good point.
The one that doesn't work, and now we're on top of that, we're going to have essentially near expiratory chest X-rays, which are even
worse.
To use, yeah, okay, excellent. Excellent. Any other question there?
Leo was from Amsterdam. So we have a few minutes, so I can actually ask a scientific question and not rush to the answer. So I want to challenge you a little bit on the statement that these high-flow patients had lower mortalities than we typically observe in patients who are intubated. Because that statement is conditional on the fact that they do not progress to invasive mechanical ventilation. But if we take all the patients and we do not know beforehand whether they're going to progress to invasive mechanical ventilation, then the mortality was quite similar to the one observed, for example, in the lung-safe study, right? Around 30–35% in the patients, irrespective of their progression. So wouldn't that make an argument in favor of including patients on high-flow nasal cannula into a definition, or at least into prospective studies that target all patients with ARDS?
Well, the lung-safe did not include patients on high flow or on spontaneous breathing. The concern we were raising when we said if you include the patients when you don't know how it's progressive, will in any case introduce a bias, because the average is the same. But if you look at the subset of the two subset of patients, the mortality is completely different. So we are talking about a completely different picture, a completely different scenario in terms of clinical evolution. So I'm not sure that if you intend to test intervention A on a patient group that has a mortality of 5% and on a patient group that has a mortality rate of 30% would make sense. Even if on average you are under the same umbrella. It doesn't make any sense to me. I don't know, probably I'm wrong, but I'm certainly wrong, right, Gordon?
Couldn't you make the same argument in patients with ARDS who progress to need VV ECMO or be prone positioned? We could compare mortality rates on patients who need progressive care versus patients and make the same conclusions.
Yeah, but if I have to design a study on ECMO where the intervention is ECMO, I would select patients that have an expected mortality that could be influenced by intervention. So I would select only the severe ARDS cases or the patients with ARDS with a PF ratio lower than 100, because I know that the signal to noise ratio of that experiment is feasible. In that case, on the other hand, if I design a randomized controlled trial on ECMO and I include patients that have a PF ratio of 300, forget the ethical aspect, the blah, blah, blah. But the mortality at 300 is not the same as at 100.
Right, thank you.
Okay, we have no time for more questions because of the time. So, yeah.
Okay, thank you very much.
Thank you. Thank you. Okay, the next speaker is Armand Mekontso Dessap. I hope I pronounced fine, from Créteil, France. He's going to talk about hypercapnia may be harmful.
Thank you very much. These are my disclosures for this talk. On experimental studies, for example, studies on cells, it has been reported that hypercapnia is beneficial. If you see, for example, in this study, submitted to hypercapnia, these cells express less NF-kappa-B, they secrete less interleukins, so globally favorable. But as we move on to more complex experiments, the answer is more complex also. For example, if we distinguish between early and late bacterial sepsis, the effect is opposite, with a reduction of lung injury in early models, but a worsening of injury in late models. For example, the effect on the bacterial growth and on the defense mechanism against infection is deleterious here. You can see that with hypercapnia we have more bacterial growth and less neutrophil phagocytosis. And if we move on to the human physiology, we also have contrasted results with cerebral vasodilatation, systemic vasodilatation, increased P50. If we focus on the respiratory system, we will have a dilation of small airways, but we will have negative effects on pulmonary vasculature. We will detail that later. And these deleterious effects will potent other effects like hypoxic vasoconstriction. So if we look specifically at the respiratory system, maybe the first thing to do is to look at the drive and the work of breathing. This experimental study is very informative. While injecting salicylic acid in the cisterna magna of this sheep, the investigators found a huge increase in the drive with a huge increase in minute ventilation. And this increase induced self-inflicted lung injury. You can see here the red bars with a decrease in oxygenation, a decrease in the respiratory system compliance, and the percentage of animals with moderate or severe lesions increasing as compared to animals which were not able to increase their ventilation because they were paralyzed after intubation. And we all know that this excess increase in the tidal volume is deleterious. These are the results of the Armand study showing that the use of increased tidal volume increases mortality. And this is also probably true for non-invasive ventilation. In this study, in our unit, the percentage of patients having NIV failure was higher if we weren't able to maintain a low tidal volume around 6 ml per kilo, which was often the case in many patients. So hypercapnia may, in this sense, enhance patient self-inflicted lung injury, especially in de novo acute respiratory failure with a kind of vicious circle that may be deleterious to the patient. And maybe some positive results of paralysis in early years are driven by this effect of controlling the tidal volume the patient develops during RDS, whatever the drive. If we now focus on more hemodynamic effects, the main hemodynamic effects of hypercapnia is to induce a potent vasodilatation. You see here the patient in black with hypercapnia have a reduced systemic vascular resistance, and this is probably one of the main mechanisms explaining the increase in cardiac output because of the reduced afterload. And this increased cardiac output will in part explain the increase in pulmonary artery pressure, but there are other explanations. The increase in cardiac output is probably not driven by an intrinsic increase in contractility. You can see in this study that hypercapnia is associated with a decrease in maximal elastance, and this decrease is partially blunted when the pH is corrected, but globally we see a less potent contractility. So the increase in cardiac output is probably the consequence of reduced afterload. And if we focus more specifically on the pulmonary circulation, we will have major deleterious effects. This is a study conducted in patients with ARDS, and you can see that the induction of severe hypercapnia by reducing the tidal volume in these patients abruptly causes a decrease in cardiac index, which is probably mediated by an afterload effect on the right ventricle, because you can see the dilatation of the right ventricle, the right to left ventricle area ratio increases, and the deformation of the left ventricle with the eccentricity index, which increases. So a pulmonary vasoconstriction driven by hypercapnia in this setting. And it is important to record that hypercapnia will also enhance hypoxic pulmonary vasoconstriction. And even during severe ARDS, there is some degree of residual hypoxic pulmonary vasoconstriction. It is demonstrated in this study with patients on ECMO, and you see that when the intensivists modulate the partial pressure of oxygen in the pulmonary artery with ECMO, the decrease in oxygenation is associated with an increase in pulmonary vascular resistance, suggesting a certain degree of hypoxic pulmonary vasoconstriction, and this phenomenon will be enhanced by hypercapnia. And globally, when you look at the literature on lung vascular dysfunction, patients presenting with acute cor pulmonale, which is the typical feature of pulmonary lung vascular dysfunction, often have higher values of PCO2 here in red as compared to those without acute cor pulmonale. We did a large observational study in more than 750 patients looking at the risk factors for cor pulmonale during human ARDS, and these are the 4 factors independently associated with cor pulmonale. The pneumonia as cause of ARDS, this is coherent with a theory of double hit because the primary pneumonia will itself alter the circulation. Second, the way we ventilate the patient, and in this study, the most culprit ventilator pressure was the driving pressure with a threshold at 18 centimeters of water. The higher the pressure, the higher the likelihood of having acute cor pulmonale. Hypoxemia, we already talked about hypoxic pulmonary vasoconstriction and hypercapnia. And we were able to construct a score, and you see the higher the score, the higher the likelihood to have pulmonary vascular dysfunction here in red, green, and also the higher the mortality, as you can see here in blue. So globally, negative effects on the circulation of the lung, and there are many studies suggesting an increase in mortality as the PCO2 increases. But it should be important to look at the mechanism driving the increase in PCO2. We did a meta-analysis of studies during ARDS looking at the effect of hypercapnia on mortality, separating the studies based on the mechanism of hypercapnia. Here you have permissive hypercapnia. The patient is basically ventilated with a very high tidal volume. You can see here the seminal studies by Amato. When they reduce the tidal volume to a protective ventilation, it is associated with increased PCO2. And you see that that permissive hypercapnia is associated with a favorable effect, a reduction in mortality, which is probably driven by the protective ventilation associated with the strategy. On the contrary, if you consider studies where patients are already ventilated in a protective way, we call that imposed hypercapnia. You see that patients with hypercapnia behave with a higher mortality as compared to those with protective ventilation and no hypercapnia. Maybe here is just a reflection of the severity of the patient, and or it may be the fact that it has deleterious effects, especially on the circulation, as we just saw. Is it a real problem? The prevalence of hypercapnia during ARDS under protective ventilation is important. You see here in the lung safe that the median value of PCO2 is 46 in moderate ARDS and is above 50 in severe ARDS. So at the bedside, we should have simple tools to try controlling. The first one is to increase respiratory rate. You can see here in the Armand trial that increasing the rate from 16 to 29 will allow to blunt the increase in PCO2 associated with the reduction of tidal volume. But this strategy will be associated with dynamic hyperinflation in some patients, and you can see here the generation of auto-PEP with an increase in the total PEEP of these patients when doubling the respiratory rate. Another caution with the increase in respiratory rate is, of course, the increase in mechanical power. The second way of doing it is to reduce the instrumental dead space, and you can see that in some patients you can really decrease significantly the PCO2, especially if the tidal volume was relatively low. There have been some techniques of expiratory lavage proposed, but that are not used in routine, but I think they could be very interesting in controlling the PCO2. And there is CO2 removal, but to date, the studies, for example, attempting to control the PCO2 while doing the ultra-protective ventilation by decreasing further the tidal volume have negative results. So in conclusion, the improved outcomes associated with permissive hypercapnia are probably attributable primarily to the benefits of the protective ventilation generating that permissive hypercapnia. But if we concentrate on patients already on that protective ventilation having imposed hypercapnia, it is generally associated with worse outcomes, either because it is a sign of severity or because it has negative effects on the pulmonary circulation, and it still has to be demonstrated that controlling PCO2 by further reducing the tidal volume is beneficial. Thank you for your attention.
Questions? I guess I'm, well, maybe the field is confused. I guess I'm still confused about the major point in the situation of imposed hypercapnia. Do we just not know whether it's a marker of severity or whether it's bad? Because it seems like the ECOR data would see, or maybe we just haven't found the right patients. Because it seems like ECOR randomization is really the only way to answer this question, to take the patients with imposed hypercapnia, remove the CO2 and see what happens. And if nothing happens, then you tell me.
Yes, the good study to do if we want to have the answer specifically on the role of hypercapnia is to control it without altering the tidal volume. And it is also probably to control it with a technique having very few side effects, because if the technique has a lot of side effects, the net effect would be a balance between the potential benefit you get and the side effects. So we tried to do a study with low flow ECOR in patients with core pulmonale and refractory hypercapnia, meaning persisting despite the increase in respiratory rate and the removal of instrumental dead space. But unfortunately, the capacity of low flow ECOR to reduce PCO2 is moderate. So at the end, you need to use a more invasive technique, but then the overall benefit could be balanced. That's why the lavage techniques seems interesting. But revisited.
But for the patient with right heart failure who has hypercapnia despite lung protective ventilation, you're not suggesting that I should increase the tidal volumes to fix the hypercapnia because of to protect the right heart, are you?
I'm not sure the result would be positive, because then you will increase the driving pressure, which is one of the actors.
Okay, excellent, excellent.
Okay,
thank you.
Thank you, Armand. There's no time for more questions. I like to tell the audiovisual department that is a change in the program. So now the following talk will be by Francesco Mojoli from Pavia in Italy, and then Amato will be later. So Francesco is going to talk about lung hysteresis to titrate PEEP.
Thank you for the introduction, and thank Marcelo for changing the place. Yes. Okay. So an approach to personalize PEEP in ARDS patient under mechanical ventilation is to set this parameter according to lung mechanics. And practically at the bedside, we can perform a decremental PEEP trial and select the PEEP according to the best compliance. Because we think that this should be associated with the best combination of lung hyperinflation and lung de-recruitment. Unfortunately, we know that a large multi-center trial failed to demonstrate a clinical advantage of such an approach, and several explanations were suggested and discussed to explain this disappointing result. And I think that one key point is that sometimes the interpretation of the decremental PEEP trial can be complicated by tidal recruitment. In fact, if you decrease PEEP and you see a decrease of compliance, this is easy to be interpreted, no? It's a lung de-recruitment. Whereas, if you see an increase of compliance, this can be associated to a decrease of lung overdistension, but also to tidal recruitment, to the fact that your PEEP is no more able to keep the lung open during the expiratory phase, and you have opening and closing. This is because the snap opening of collapsed alveoli generates larger volume, and then we measure an higher compliance compared to what happens when you set a PEEP that is able to avoid tidal recruitment and opening and closing. So a PEEP able to stabilize the alveoli. A suggestion comes from this experimental study from Peter Riemensberger. He performed a decremental PEEP trial, keeping always the same plateau pressure, around 30 centimeters of water, and decreasing PEEP by step of 5 centimeters of water. And then perform a tidal pressure volume loop, so not a conventional pressure volume loop, but a pressure volume loop between the PEEP level applied and the plateau pressure and back. And he observed decreasing PEEP from 15 down to 10 to 5 and 0, a step-by-step increase of compliance that was associated with a fast, let's say, exponential increase of tidal hysteresis. So this improvement of compliance was not associated with an increase in number of the patent alveoli, but was associated to tidal recruitment. That is something that we don't like that much. And this is, let's say, respiratory physiology. From a physics point of view, lung hysteresis, tidal hysteresis, is a way to measure the so-called unrecovered energy. That is the amount of energy that is dissipated into the lung tissue each breath. So with the same, the same tool, the pressure volume tool, we can perform two different maneuvers. A full pressure volume curve, if we want to answer the question, how big is the potential for lung recruitment in my patient? Or a different maneuver, a tidal pressure volume curve, from PEEP up to plateau pressure and back, if we want to answer the question whether our PEEP setting is able to avoid tidal recruitment. And also, from the physics point of view, if we want to assess the unrecovered energy in our patient. So the idea was to use a combined approach, looking both at compliance and tidal hysteresis, to be able to detect, when you decrease PEEP, the two unfavorable mechanical effects of a PEEP step down. Lung recruitment can be detected as a compliance decrease, of course, and tidal recruitment, opening and closing, like a sudden increase of tidal hysteresis. So we performed a study on 38 ARDS patients under mechanical ventilation, performing a decremental PEEP trial where we increase PEEP by 6 centimeters of water above the clinical PEEP, so the baseline level, while keeping the same plateau pressure. And then we decrease PEEP step by step by 2 centimeters of water each step. And at the end of each step, we perform this tidal pressure volume loop, computing the area enclosed in the loop, that is the tidal hysteresis, that was normalized on driving pressure, in order to be able to compare this parameter at different steps. And we observe 3 different patterns. This is one. This patient had a clinical PEEP of 12, so we studied a range of PEEP from 18 down to 6. This is the tidal PV loop at 18 of PEEP, up to close to 30 centimeters of water of plateau pressure, and you see tidal hysteresis is quite small. But as soon as we decrease PEEP in this patient, we observed a fast exponential increase in tidal hysteresis. So we call this patient a high tidal recruiter, because since the first step down of PEEP, it seemed that tidal recruitment was occurring in the lungs of this patient. And on the right of the slide, you see in compliance, that are the open circles, and tidal hysteresis, the open squares, as a function of PEEP. In this specific patient and pattern, this combined approach clearly changed the interpretation of the decremental PEEP trial, because suggested to keep PEEP, a very high PEEP at 18 centimeters of water, because with this approach, we are able to identify tidal recruitment as the main reason for the improvement of compliance. Completely different patient is this other one, the second pattern. The clinical PEEP in this case was 10 centimeters of water, so we tested a range of PEEP between 16 and 4. You see very thin hysteresis, so very, very small, and nothing happened in this patient down to 4 centimeters of water of PEEP. So no increase of tidal hysteresis, no generation of instability in the lungs of this patient. All the loops are almost superimposed. We call this patient low tidal recruiter, and in this case, the two approaches were similar, because the confounding effect of tidal recruitment was not there. And final, this last pattern, last but not least, because actually this was the relative majority of our patients show this pattern. Clinical PEEP was 12 in this patient, so we tested a range of PEEP between 18 and 6. And again, moving from 18 to 16 to 14 to 12, nothing happened. But as we decrease PEEP below this level, boom, we observed a fast exponential increase of tidal hysteresis. And we call this patient the biphasic tidal recruiter, or with a biphasic pattern. In this case, the clinician was right, because in setting PEEP at 12 centimeters of water, because this was the lowest PEEP value able to avoid opening and closing in this patient. So we observed these three mechanical patterns: high tidal recruiter, low tidal recruiter, and biphasic tidal recruiter. But in the end, we detected two different and very well separated rate of change of tidal hysteresis when PEEP was decreasing in our patient. You see here tidal hysteresis as a function of PEEP in all the individual patients, divided according to the mechanical pattern. So we observed a very fast change in tidal hysteresis in red, in high tidal recruiters, and in the fast phase of biphasic tidal recruiter, and a very slow increase of tidal hysteresis in low tidal recruiters and in the slow phase of tidal recruiters. And this is very consistent with experimental data showing almost the same, no? So here you see the change of tidal hysteresis when you increase tidal volume and driving pressure in two different conditions, high and low recruitability. So in low recruitability condition, in green, you see a very slow increase of tidal hysteresis and an exponential increase in red of tidal hysteresis when a high recruitability condition was the model. And to me, even more interesting is that it seems that there is a sort of threshold. Almost all the values that we recorded in high tidal recruiters were above 100 ml of normalized hysteresis. Almost all the values that we recorded in low tidal recruiters were below this value. And look at the biphasic pattern. The point where there is this sudden change in the slope is very close to this value. So in a post-hoc analysis, we found that a value of tidal hysteresis of 100 ml or larger was a very good predictor of tidal recruitment at the next PEEP step down. Finally, what was the PEEP suggested by the different approach? In green, you see the clinical setting. In orange, the best compliance approach. And in blue, the combined approach. The best compliant approach in this population almost always suggested to decrease PEEP irrespective of the mechanical pattern, whereas the combined approach suggested to increase PEEP in high tidal recruiters and to decrease PEEP in low tidal recruiter. And this was associated with the capability to keep at low level lung hysteresis. Remember that lung hysteresis is in the end the amount of energy that is dissipated in the respiratory system of our patient at each breath. So to conclude, we found that the improvement of compliance associated with a decrease of PEEP can be often associated to tidal recruitment. Tidal hysteresis can be used to detect this problem, and a combined approach looking both at compliance and tidal hysteresis can help the interpretation of a decremental PEEP trial with the, let's say, side effect to limit in our patient tidal recruitment and the amount of unrecovered energy. Whether our patient will appreciate a PEEP setting associated with the best combination of hyperinflation, de-recruitment, and atellect trauma is to be determined. Thank you for your attention.
Thank you, that was excellent. Any questions? Yes.
Hi, Alessandro Santini from Milan. Thank you very much, very interesting data. I didn't understand at the beginning if the PV loops are done in a static way, how they were done, like static with small amounts of, I don't know, 100 mLs per step or whatever. And then also, if you can comment on, you call it tidal hysteresis, but at the end of the day, the lower the PEEP, the higher the span of pressure examined. So it's not, I mean, recruitment can happen all along this higher span. So just a caution about calling it tidal hysteresis, if you can comment. Thank you.
Yeah, thank you for these two questions. Yes, of course, the PV loop was performed with low flow inflation and deflation. So in this ventilator, you can set the pressure ramp. So we selected the slowest pressure ramp, that is 2 centimeters of water per second. So the max flow is usually even below 50 ml per second. So it's a quasi-static pressure volume loop and is therefore related to alveolar pressure. Yes, the decremental PEEP trial was performed keeping a constant plateau pressure. This was due to a technical limitation of the tool in the ventilator. So it was a decremental PEEP trial with incremental driving pressure. This was the reason why we decided, of course, to normalize the area of hysteresis on the driving pressure, to be able to compare at different steps this parameter. And of course, this unconventional decremental PEEP trial probably magnify the problem of tidal recruitment. But the aim of the study was not to, let's say, quantify the problem. Not the aim was to is a proof of concept study. Was to show how to detect the problem when you have this problem.
Okay, thank you, Francesco. You had to go to your next room, your next lecture.
Thank you very much.
So as I said in the beginning, was a change in the order of the talk. So now is the time for Marcelo Amato from Sao Paulo, Brazil, to talk about how can we improve recruitment maneuvers.
Thank you, Jesus. Good afternoon. So, may we have the slides? So, I'm going to talk a little bit about the monitoring and a little bit about how to improve. So, why to recruit? Despite all the damage caused by the Ards trial, and I think the disappointment with this study, I still believe that this meta-analysis is not far from reality, so there is this equipoise in terms of the benefits. And I think if we add now what we have learned, maybe there is still room for improvement and new research on this topic. So it's still equipoise. So which is the image we have in mind? What is a high recruitability? Is an animal like this or a patient like this? And typically, we like to do recruiting maneuvers with fixed delta pressure. This is proven already that this decreases the chances of barotrauma or ventilator-induced lung injury. And this is a patient that, for instance, there is no recruitability because it's already recruited, or could be a fixed consolidation that cannot be recruited. So this is what we have in mind, and now there is some research in terms of, okay, can we know upfront if this patient is recruitable or not? And more or less, this was the original intention of this multi-center physiological study, but we had also some other outcomes that are very interesting to show here. So there were, the whole protocol was something like this. We have the clinical PEEP, and then we decreased PEEP, increased to 16. Here we measure the recruitment to inflation ratio as proposed by Laurent Brochard and Lu Chen. And then we also did a recruitment maneuver in some patients up to 24 and some other patients to 30. Later on, I'm going to comment on this. And then 30 of PEEP, but then you have 15 of delta pressure, which means that you reach 45. So maximum pressure, 45. And then we had the decremental PEEP steps. So how did we assess in this study the recruitability? I'm going to talk about the Costa method, which is a method that we use most of the times when we use electrical impedance tomography. And multiple brands of EIT now use this method. The Costa method is very nice for two reasons. First is that you can clearly identify the, let's say, the proposal it's very clear to detect which should be the, let's say, ideal PEEP. So you have the calculation of collapse, you have the calculation of overdistension, and then the crossing point is very interesting because now lots of recent studies have shown that this point coincides with a transpulmonary pressure slightly positive. So it's exactly the transpulmonary pressure that you have in your lung when seated in this room. So this is the transpulmonary pressure that all the mammals, they like. And the normal physiology of mammals is typically trying to set a transpulmonary pressure of between 0 and 2. Is when your airways are open and you don't have too much collapse and not also overdistension. This method is also very good because we did validation studies comparing CT and EIT, and the coincidence is very large. And in fact, the Costa method was planned to be, let's say, a good correlate or a good surrogate of CT collapse. And this is a validation study showing that the correlation between CT and EIT is very nice. Something interesting, just for you to understand the principles also. So this is a patient supine and Trendelenburg. You see the crossing point here is at 11, and when I have the Trendelenburg, the crossing point goes to 16. Why? Because now the pleural pressure is more positive, and then I need a higher PEEP to overcome this. If I had an esophageal balloon, I would come to exactly the same conclusion. Another example, if I put some weight on top of the pig, this was the curves before the weight. So this animal would be very fine with a PEEP of 5, but after the weight, there is a complete shift of all the curves to the left, and now this animal is going to be fine with 14 after putting some weight. So this is a model of obesity. And obese patients, they behave exactly in this way. Okay, using this method, applied in this big population of 100 patients, 107 patients with COVID, we got this result. So this is the number of patients, and this is the let's say, how much of the parenchyma could be recruited at those pressures that I showed you before, plateau pressure of 45. So and then we divided in three tercios. So we have the high recruiters, medium, and low. If we compare this result with previous studies, in black, you have the famous study from Gattinoni that was published in the New England Journal, where he showed that the average or median value for recruitability is 13%, which means that only 1/10 of your parenchyma can be recruited. So it's very questionable with this very low number if it's worth it. Then we had the study of Proti that with the same technique, he found a more optimistic value, 25%, and the distribution is much more to the right, so means that some patients, they reach 50%, so half of the parenchyma was closed and after the maneuver was open. And now for the COVID patients, we got an even higher value, so 32, so 1/3 of the lung was not working and after the maneuver was working. So it's a much more optimistic result. This was one of the results of the study. Another interesting result was that, so low, mid, and high recruitability, and let's see the crossing point. Here it was 10, and for the high recruiters, 16. So this graph suggests that the patients presenting more recruitability, they need higher PEEP. A small suggestion, but the reality is not like this. I'm going to show you why. So obviously these patients, they present big overdistension if you use the wrong PEEP and a high PEEP, while these patients, they present very little overdistension if you achieve, for instance, 24 of PEEP. But this is what I told you, that the reality is not like this, because this is low, mid, and high recruiters. Look, these dots is the crossing point of each patient, so which means that this is the PEEP causing slightly positive transpulmonary pressure. And look at this, there is a big overlap. So, which means that if you are a big recruiter, doesn't mean that you need a high PEEP. This is very important clinical conclusion. For instance, some patients here, they needed just 10 of PEEP to recruit more than 1/3 of the parenchyma. This is very interesting. Again, plotting these points, this is body mass index, this is the crossing point, so this is the ideal PEEP, the physiological PEEP that we mammals will love. It's much more than we are used to think about. This is post-operative patients, so they have normal lungs. So there is a striking correlation with body mass index, which means that we should be using more PEEP in obese patients. And this is COVID patients. And the interesting thing is that they're almost the same. I was very surprised about this result, because this means something that I never imagined before, that the PEEP, let's say your need for PEEP, is much more an anatomical issue, individual shape of the thorax, than the lung weight. This was very interesting, because the lung weight is responsible for a difference of 2 centimeters of water. And I have confirmed this in animals also. So PEEP is an anatomical issue. It's a property of your body, shape of the body. If you increase your body mass index by 3, you need 1 centimeter more of PEEP. So then, just also something that was correlated with these results. Previously, we did some studies of recruitment maneuvers in obese patients in Boston, because they have the super obese patients. And then if we had the super obese, and based on these data, that the pleural pressure is correlated with obesity and the need for PEEP the same way. So then for the big, very obese patients, the highest pressure was 50, not 45. And then also we started titration in some of these patients at 30 of PEEP, because some of them, the crossing point was at 26, 28 of PEEP. And we put an esophageal balloon, transpulmonary pressure, 0. When we applied this PEEP in super obese patients, so the average PEEP was 22, average. There was an interesting result, especially this is a graph of overdistension, and this is collapse. You have always 3 situations: baseline, PEEP, and after the recruiting maneuver. These two situations is the same PEEP. The interesting thing is that, as expected, we reduced the amount of collapse, but also we reduced the amount of overdistension. This was very reinforcing. The driving pressure dropped by almost 10 centimeters of water. So this was very, it's a very promising result. And also something that was very interesting, it's good to know this at the bedside, is that if you have high pleural pressure, you are protected against hemodynamic problems. In this study, we measured transmural right ventricular pressure and transmural left ventricular pressure. This is before and after the recruitment. You can see that if the animal is thin, skinny animals, after the recruiting maneuver, you increase the afterload for the right ventricle, and left ventricle, you have a decreased afterload, because now you have a big pressure surrounding the left ventricle. But if you are obese, look at this. The transmural afterload of the right ventricle is improved. So you decrease the afterload to the right ventricle. So for this patient, recruiting is a relief for the heart. And we have seen some patients that after the recruitment, I could remove completely norepinephrine. Also, something that is very interesting about the Costa method is this. So if I split the population now, not intersios, but just half in the median value, which means that I have recruiters and non-recruiters. So high recruiters and low recruiters. And then how much I can reduce driving pressure after the recruitment? A lot. And you see some patients, they had a reduction of almost 10 centimeters of water in terms of driving pressure, which is a lot. But the nice thing about the Costa method is that for every single patient, you are not, the benefit here is moderate, but you are not causing any harm, you are not causing any increase in driving pressure. And when we did in the Ards trial, just for your reference, 1/3 of the patients, they had increased driving pressure after the maneuver, which means that we did very poorly. And so I think we need better technology to do this. Okay, this is why I believe that this method is much better. And again, if you are more obese, body mass index increases, you can reduce further the driving pressure. So these maneuvers are especially helpful for obese patients and high body mass index. Okay, almost at the limit of my time, so I'm going to finish talking a little bit about how to identify those patients at the bedside. This is typically a patient in which the image on EIT is like this. So if you make a line here, you are going to see that you have much more ventilation in the ventral part than in the dorsal part. And this is the image for this patient. So this image now, after tons of data, is almost the diagnostic of dorsal atelectasis. And this is very useful at the bedside, because if you see a patient like this, in which you have less than 40% ventilation, this is a signal that this patient maybe should be submitted to a recruiting maneuver. And if you're not successful and you cannot increase this value above at least to 50%, this is a patient that has to go to prone positioning or some lateral positioning. We have some data to show about this, and we are going to show in the late afternoon. But this is a strong signal that this patient has dorsal atelectasis. And in fact, we are now working with this, let's say, morphological characteristic of the patients in the EIT. And we can see that whenever we have some quadrant in the dorsal part that is compromised, so these three patients are patients that are potentially good for a recruiting maneuver or a positional change. And these patients typically have a worse oxygenation. So the message here is that we need better identification of the patients to be recruited, and then we need better technology to assess how to treat and how much pressure we need for each patient. Thank you very much.
Questions? Marcelo, I wonder if you could help us think a little bit, how much further mortality benefit do you think there is out there to be obtained by making the EIT pictures look better and recruiting optimally and everything? Like what more benefit can we, in the patient now who's got optimal lung protective ventilation from everything else that we know, how much more benefit? Because if we're going to wait for some of these things to be tested in trials, which maybe we won't have to, maybe we'll be persuaded by the pictures alone. But if we do, how much, I'm just wondering just how big this trial will need to be to find whatever the mortality benefit is that we're looking for.
Yeah, excellent point, Gordon. And I believe very much in the mediation analysis of driving pressure. And when we compare the benefit of reducing driving pressure by a proper PEEP or by a reduction in tidal volume, we got exactly the same coefficients. So, and experimentally also, I can have the same decrease in inflammation by changing PEEP and reducing driving pressure, or by reducing tidal volume. I get exactly the same results. So I believe that how much you can decrease driving pressure is telling you how much is the effect size. And then I think if we do a little bit of predictive enrichment, so we select patients in which we can reduce, and I think it's realistic to think that we can reduce by 5 or 6 centimeters of water. If you think about the Armand trial, the reduction in driving pressure was 8. So reducing by 5 or 6, it's close. So I think then we could have a trial.
And remind me, because I honestly don't remember. So there was no reduction in driving pressure in ART?
No. In the Ards, it was less
same,
than
just
1 centimeter of water, which would lead us to 12,000 patients to be a positive trial. And then the side effects overcame.
Yeah. Excellent. Thank you.
I'd like to make a comment. Marcelo, because after your lecture, I think it's a hope for those people who believe in recruitment maneuver, to do it again, because after the Ards trial, you know that many people decide not to do any recruitment maneuver in their patients, and I think I'm glad to hear today that you are pursuing this.
Thank you very much.
Okay, we are on time. Thank you to my colleague, my great moderator, Gordon Rubenfeld.
We have a little time, yes? Like before the next one? No? 3:20?
No, but eventually.
Should we just get started early, or should we take, no? What do you want to do?
I think most people are here at 5:15, so we can wait. If you want to make another question to the previous speakers, that will be fine.
I do, I'm sorry.
One.
Sorry, Marcelo, to make you stand up again. Nice talk, thank you so much. I have some, by the bedside, I would like to ask you more from the scientific standpoint, but as a clinical perspective, First, if the super obese patients or very obese patients, you told us that apparently there's a major component for the chest wall compliance and the abdominal compliance. So position makes a very important case for them, apparently. So you mean that they should be seated, or is there optimal position for them overall? The second thing is, what's the importance of muscular relaxation in this case? Maybe plus or minus the foot balance, of course. And the third is, by your NICT chest that showed ARDS on those lungs that would be recruitable, I haven't seen much about pleural effusion and the amount of liquid that's inside the chest compartment, and it wasn't being dealt with. Maybe sometimes you cannot use diuretics to get rid of them, and you might need to taper them out to remove them. Is this an important component regarding the transpulmonary pressure, or no? So, thank you.
Okay, wow. These are three difficult questions. Okay, so let's start with I'm not going to answer in the same order. So I think the position is something very important, because we did an ancillary study on position, and to my surprise, 30 degrees for an obese patient, it's the worst position, because then the abdominal compartment compress the thorax even further. So for them, sometimes completely supine is better, which means that you cannot, there is no easy solution, so the better solution is lateral or prone. And then also lateral, you really have a display, so the weight of the abdominal content is not any further in the diaphragm, but goes to the bed or to the belly wall. So this is one of the issues. So, but 30 degrees is not the solution, not even seated, because they compress the chest. About pleural effusion, I think I recall the study of Luciano Gattinoni and also my experience. So pleural effusion works as a load, as an offset of pleural pressures. So it's exactly like being obese. So pleural effusion is exactly the same as being obese. So you need a higher recruiting pressure and a higher PEEP. But it does not affect the chest wall compliance. This was well proven, okay? And likewise, also this obesity problem is an offset of pleural pressure, but then for instance, you need a higher pressure to keep zero transpulmonary pressure, but to move 500 mLs, you need the same delta pressure as a normal patient.
Okay, I think you can continue, Gordon.
Shall we go on? I know it's a few minutes early, but hopefully we won't have people that are waiting exactly for 3:20. Thank you, Marcelo. Next we have Leo Heunks, I hope I'm getting that correct, from Erasmus University in the Netherlands, on the effects of PEEP on the respiratory pump.
Okay, thank you very much, Gordon. Yes, so we have discussed quite a lot the effect of PEEP on the lung, or maybe hemodynamics, but I think the effect of PEEP on the respiratory muscles is largely neglected. So I'm happy I can talk about that for like the next 15 minutes or so. So I don't have any conflicts of interest related to the current presentation. So what I would like to do is first discuss the effect of PEEP on diaphragm geometry, the effect of PEEP on diaphragm effort in critically ill patients, and after that, the prolonged effect of PEEP on the diaphragm. So right here you see the diaphragm. That's that fantastic dome-shaped muscle positioned between the thorax and the abdomen. And there's two parts that's really important. The top, the tendinous part, and the lateral part, the zone of apposition, the place where we generate the pressure, the place where the muscle fibers are located. And as you can imagine, upon contraction of the muscle fibers, the top of the dome will move downwards. Also important for this presentation, and I'm sure that you're aware of that, every muscle has a length-tension relationship. So there's an optimal length for contraction. If the muscle is overstretched, you can generate less pressure, and if it's shortened, it will generate less pressure as well. And the biochemical explanation is that you need a certain overlap between contractile proteins, between actin and myosin. So in this study, healthy subjects were ventilated with different levels of PEEP while in a quite sophisticated four-dimensional MRI. And I'm going to show you some of the results right here. So if we increase the level of PEEP, we find a downward movement of the top of the diaphragm dome. In this healthy subject, almost 3 centimeters. So right here, for all the subjects, 5 of PEEP, 10 of PEEP, 15 of PEEP, there is a downward movement of the top, but also the anterior and posterior part of the diaphragm. More or less as expected, I guess. The interesting thing is, if the top of the dome moves downward, the zone of apposition, so the muscular part, becomes shorter, becomes thicker, and also shorter. In fact, it's not this simple at all. It's not like a moving downward cylinder. If you apply PEEP, there's an expansion of the thoracic cage. So what is actually happening, that the diaphragm becomes a widening cylinder. And that has important implications. Just a small sidestep, because you would say, yeah, this is like in healthy subjects, who cares? Well, we did more or less the same in ICU patients, so ventilated patients with ARDS, at this time not in MRI, but with quite sophisticated ultrasound, and we also found that increasing the level of PEEP results in a downward movement of the top of the diaphragm. Okay, so let's go back to the healthy subjects again. So we looked at the contractile properties of the diaphragm. So double balloon catheters, gastric esophageal balloons were inserted, and the phrenic nerves were magnetically stimulated to investigate the pressure generating capacity. And as you can see here, the higher the level of PEEP, the lower the level of pressure that could be generated. So PEEP impairs pressure generating capacity of the diaphragm. In fact, if we looked at the neuromuscular efficiency, so how much pressure do you generate for a certain drive, it decreased with PEEP. Again, a small sidestep, and I think this is important as well. What is the effect of PEEP on perfusion of the diaphragm? So this is an animal study, rats mechanically ventilated at different levels of PEEP, low and high PEEP, and they measured perfusion, blood flow in the diaphragm. And as you can see right here, increasing the level of PEEP actually impaired diaphragm perfusion. And this was at least partly explained by increased vascular resistance. And this is a very nice study because if they open up the abdomen or the thorax, you don't see this phenomenon. So this is really pressure related. So to conclude this first part, what happens if we apply PEEP, at least to the diaphragm, it results in a shortening at the zone of apposition. That results in a reduced contractile efficiency, and also PEEP impairs perfusion of the diaphragm muscle, at least in this animal model. So what happens if we apply PEEP to the effort generated by the patient? This is a fantastic study published in the Blue Journal a couple of years ago. Patients with ARDS at 2 levels of PEEP. So right here, this is the airway pressure, obviously during an assisted mode, airway pressure and esophageal pressure swings. And as you know, the esophageal pressure swings reflect the effort generated by the patient. So if we increase PEEP from 5 to 15 centimeters of water, you'll see right away that swings in esophageal pressure become smaller. So in this representative patient, respiratory effort decreases when you do increase PEEP. And if we look at the data for all patients, right here, 5 of PEEP, 15 of PEEP, esophageal pressure swings, so the lower, the less effort generated by the diaphragm, increasing PEEP, in this case, halved the effort generated by the patient. And the effect was very, very consistent, at least in this study. Honestly speaking, my clinical practice is a little bit less consistent, but at least in these patients, it was very consistent. And increasing PEEP, as expected, reduced tidal volume. It's an important observation, I think. But then the question is, why does PEEP actually reduce respiratory effort? And there's more than one explanation. And looking at respiratory drive, as reflected here, electrical activity of the diaphragm might provide an explanation. But now things become rather confusing. Because in some patients, increasing PEEP decreases respiratory drive. And if respiratory drive is decreased, you can imagine effort decreases. But in some patients, increasing PEEP actually increased respiratory drive, but still effort decreased. So that makes us think. So right here, let us reflect a little bit again on the feedback of respiratory drive. So respiratory drive is generated in the respiratory centers of the brainstem, and there are actually at least 3 feedback pathways. The reason why you're sitting here in this room and you are breathing is because of arterial CO2, or more precise, arterial pH. There's an effect of the cortex. I mean, you can hyperventilate if you become agitated or whatsoever. But right here it's important, there's quite a lot of irritant receptors within the lung. So if there is consolidation, there might be an increase in respiratory drive. So you can imagine if you apply PEEP, the lung becomes more homogeneous. This becomes less important, and respiratory drive decreases, right? So what may happen? You increase PEEP in your So we increase PEEP. In some patients, respiratory drive will decrease, respiratory effort will decrease. So most likely in these patients, lung homogeneity has increased. While in other patients, the increase in PEEP results in increased respiratory drive. Therefore, there must be a decrease in neuromuscular efficiency, resulting in decreased effort. And these are the patients where there's probably a large effect on a zone of apposition. Remember the widening cylinder concept. I'm not sure if this is the explanation, but when I was working on this presentation, I think this is a reasonable explanation for the different effects. Okay, so far we have been talking about the effect of PEEP on the inspiratory effort. So let's talk a little bit about the effect of PEEP during expiration. And this is a very nice study in ventilated children. Right here, this is a PEEP of 5, release of PEEP, again PEEP of 5. I have a little difficulty. All right, it doesn't matter. Below, you'll see the airway pressure, and in the upper signal, you will see electrical activity of the diaphragm. So when PEEP is released, and expiratory diaphragm activity actually increases. And it's very well known. A pediatric intensivist will recognize that the diaphragm develops tonic activity the diaphragm develops a tonic activity when PEEP is released. It looks like the diaphragm tries to recruit the lung. And this is also a very nice experimental study published a couple of years in the Blue Journal. Pigs with ARDS, right here on the y-axis electrical activity of the diaphragm, and on the x-axis time of expiration. So this is a single expiration divided into quartiles. In this pig at 15 of PEEP, and you can see there's a rapid decline in electrical activity of the diaphragm. But now if you're going to decrease PEEP, you'll see that the electrical activity of the diaphragm in the expiratory phase increases. Or what the authors nicely showed, called breaking expiration. The diaphragm breaks expiration. And it's not only the drive, the EDI, but also the transdiaphragmatic pressure. So if you decrease PEEP, most likely the diaphragm is gonna break the expiration. Fantastic observation. So to conclude this part, I think if you increase PEEP, at least in the studies, quite consistently, there's a reduced inspiratory effort. But increasing PEEP has a quite an unpredictable effect on the inspiratory drive, and increasing PEEP reduces the expiratory drive and effort. At least in children and pigs, it seems like adults have a little bit less of this vagal activity, have a little bit less of this tonic activity of the diaphragm. So the final part, 2 minutes, is what is the prolonged effect of PEEP? Again, remember, this is how you are sitting in this room. If I apply PEEP, the zone of apposition is shortened, right? But the interesting thing is what happens when we release PEEP. And that's what we investigated in this experimental study. Rats were ventilated with PEEP, and we measured certain things in diaphragm strips, so strips obtained from the whole diaphragm. And interestingly, what we found already, but in rats things are going quite fast, after 18 hours of mechanical ventilation, the optimal length for force generation of the diaphragm was reduced. So if in the control animals the optimal length of force generation was around 2.2 centimeters, for animals ventilated with PEEP it was around 2 centimeters. So the muscle has become shorter. This is what we have called longitudinal atrophy of the diaphragm. And I'm not going to discuss it into too much detail, but what actually happened, which we analyzed with quite sophisticated techniques, is that the muscle is going to expel sarcomeres. It's going to expel actin and myosin. So the actin and myosin doesn't become shorter, but you're just going to expel a couple of these sarcomeres, contractile units. You could say, who cares? I mean, it's a physiological adaptation, right? Well, remember, this is how we started. So we provide PEEP. The zone of apposition becomes shorter. Muscle adapts. So again, there's an optimal length for force generation. But now as clinicians, we're going to release PEEP during a spontaneous breathing trial. And the adapted muscle is overstretched. And this could be an explanation for a failed spontaneous breathing trial. I mean, this is our hypothesis. I'm not saying that this is going to happen in your patients tomorrow, but I think it's a reasonable hypothesis when the length of the diaphragm is suddenly increased when PEEP is released. Okay, so to conclude, Mr. Chairman, I think I've shown that there are key effects of PEEP on the respiratory pump that we don't consider too much in clinical practice, but that are important. There's a shortening in the zone of apposition, and that affects contractility. There's reduced effort, unpredictable effects on drive. Low PEEP may result in activation of the diaphragm in the expiratory phase, tonic activity to recruit to the lung, and with prolonged PEEP, at least in experimental models, the diaphragm develops longitudinal atrophy, and it's our working hypothesis that this is a mechanism for failing spontaneous breathing trials, at least in some patients. Thank you very much.
Any question from the audience? Marcelo?
Leo, as usual, excellent talk. So any idea how long it would take to expel parts of the, and how long it should be reversible, but then do you have any idea how long it takes?
No, these are excellent questions. At least we know in rats, it develops really rapidly. Within 18 hours, we were quite surprised.
Oh. Okay.
For humans, we don't know. At this time, we are working on, well, we're working on studies to show it, and it's not so easy to show it in humans, right? The only way you can do it is post-mortem. We need the total diaphragm, because for our other work, we just take a biopsy of the diaphragm, we're happy. But now we need autopsy material to get a complete diaphragm so we can measure the length of the diaphragm muscle fibers from the central tendon to the rib cage, and then match, well, length, weight, etc., and see if there's a difference in length of the muscle. So this is a question that's really difficult to address. The other question is going to be, I'm not sure if I'm going to say all my research ideas, but one of the things could be, of course, is just looking functionally what happens with the diaphragm if you release PEEP. What happens with the neuromechanical efficiency?
Oh,
this
is a very nice idea.
That's a nice idea of working.
And using imaging, can you measure the length of the diaphragm using like?
Yes, actually we can. So I mean, I showed you a little bit of our work on MRI, and the developments in MRI are really amazing at this moment. So like a couple of years ago, you could not actually visualize the diaphragm with MRI, but right now you can, and you can measure the length, you can measure the central tendon, and you can measure the muscular part. So yes, we can, and that's what we're actually working on. So hopefully next year.
Okay, thank you very, very much.
Thank you.
The next speaker is Jean-Louis Teboul from Paris on fluid management.
Thank you very much. Good afternoon, everyone. So I will talk about fluid management in ARDS patients. My conflicts of interest are on this slide. So I would like to start by a few words about physiology. And this is a relationship between lung edema, expressed here by extracellular lung water, and the pulmonary capillary hydrostatic pressure at the site of the filtration. If you have a normal lung capillaries permeability, you have this kind of relationship. No change in lung water if you increase capillary pressure until critical pressure, above which you have an increase in lung edema, lung water. Sometimes you have increased inflammation in the lung. This is more or less ARDS. And you have an increased lung capillaries permeability. And you have different relationships. First, you have critical pressures which are lower in case of high permeability, but also the slopes of the lines are different. So if you have a value of 15, for example, for capillary pressure, this value can be associated with different values of lung water depending on the alteration, the severity of the alteration of permeability of the lung capillaries. So now, as you know, patients with ARDS may experience hemodynamic instability due to different mechanisms associated with sepsis or bacterial infection, secondary bacterial infection or fungal infection, whatever. And clinicians may be tempted to give fluid to restore adequate hemodynamic conditions. However, often patients were already fluid resuscitated for hours or days. Also, there are potential risk of worsening pulmonary edema, especially in those conditions of increased lung permeability. Just to go back to this cartoon, if you have an alteration of lung capillary permeability, you start from 12, for example, for the capillary pressure, and if you give fluid, by definition, you increase a little the capillary pressure, but you increase a lot the lung water. So we have to be very careful when we give fluid to this kind of patients. In addition, it was shown in many studies that a positive cumulative fluid balance can be associated with mortality. This was demonstrated in sepsis, in septic shock patients, in acute kidney injury patients, etc. But even in ARDS, this is a study we did some years ago with Mathieu Josviak and Zweimele in our unit, and we included 200 patients with ARDS, severe ARDS when you look at the mortality rate, and the mean fluid balance was an independent factor associated with mortality in these patients. Also, we have no certainty of fluid responsiveness in general in critical patients, especially in ARDS patients. This is a study we did more than 20 years ago now with Frédéric Michard, and we pulled all the studies that addressed the issue of fluid responsiveness at that time. And among 400 patients, only 52% of these patients increased their cardiac output in response to fluid administration. Therefore, not all the patients are fluid responsive in the ICU, even in shock. So, because of all these reasons, we need to assess the fluid infusion benefit-risk ratio in an individualized way. How to assess this? The benefit can be assessed by predictors of fluid responsiveness, of course, and the risk can be assessed by markers of the risk of lung edema, for example. Let's start by the predictors of fluid responsiveness in ARDS patients. In septic patients, as you know, in septic shock patients, as you know, we have a lot of recommendations. And one of the recommendations is to say, use dynamic over static variables to predict fluid responsiveness. So we cannot use CVP, for example, but it is better to use dynamic variable. What is a dynamic variable? This is something which can quantify the slope of the Frank-Starling curve at the time you decide to give a treatment to your patient. You know that you have different Frank-Starling curves depending on cardiac contractility. And if you have the slope, if you know the slope, you can have an idea of fluid responsiveness. So we have some tests, dynamic tests or dynamic variables, which can indicate the slope of the Frank-Starling curve. We could have passive digressing tests. We could have end expiratory occlusion tests. We could have the respiratory variation of stroke volume, pulse pressure variation, and stroke volume variation in patients who are mechanically ventilated, but many of these patients, of course, with ARDS are mechanically ventilated. Passive digressing test is a good test. It can be done in patients with or without intubation. It is interesting because it mimics fluid challenge. You increase preload and you look at the change in cardiac output or stroke volume at the same time. And the expiratory occlusion test also in patients who receive mechanical ventilation is very interesting because it also mimics fluid challenge, because by interrupting the ventilator at the end of expiration, you increase preload. The patient increases preload, and you can look at the change in cardiac output at the same time. These two tests, we tested these two dynamic variables with Xavier Monet and others in my unit some years ago in ARDS patients. We chose patients with a respiratory system compliance less than 30 centiliters of water, ml per centiliters of water. And on the left part of the slide, we have the effects of PLR, passive lag rising, on cardiac output. As you can see, this prediction is far better in terms of area under the ROC curve, 0.94, compared to the prediction by pulse pressure variation alone, only 0.69. On the right part of the slide, the effect of end expiratory occlusion on cardiac output, the other test, and also the prediction is very good compared to pulse pressure variation. But the major limitation of these two tests is that we need a real-time stroke volume or cardiac output measurement. It is mandatory. And this is why sometimes we prefer to use, when we have no cardiac output monitoring device, the variation of pulse pressure variation. The major advantage is that it does not require any cardiac output measurement. I don't want to go into detail, of course. You know that when you have a high pulse pressure variation in a patient who is ventilated, but with a tidal volume of at least 8 ml per kilogram, you can predict fluid responsiveness. And the opposite is true, fluid unresponsiveness, which is also a very important concept. The problem is that in ICU patients, it is difficult to use pulse pressure variation or stroke volume variation. In particular, in case of arrhythmia, in case of low tidal volume ventilation, which is normally the case in ARDS patients, in case of persistence of spontaneous breathing activity, which is sometimes the case in this kind of patients. This is why, in some of these situations, it is interesting to look at the changes of pulse pressure variation during some tests. Not pulse pressure variation alone, but the changes of pulse pressure variation, for example, during a tidal volume challenge. We know that PPV is not good enough to predict fluid responsiveness in case of low tidal volume. This was demonstrated by many studies. With Sheila Malhotra from Mumbai, we confirm this in patients ventilated with a low tidal volume, 6 ml per kilogram here. The area under the rocker for the prediction of fluid responsiveness was not good enough, but what we did is we increased tidal volume from 6 to 8 ml per kilogram during 1 minute only, and we looked at the changes in pulse pressure variation. The value at 8 was better in terms of prediction of fluid responsiveness, but what was far better was the difference between the value of 8 and the value of 6, and we found a cutoff value of 3.5. So in other words, if you have a PPV of 7%, when the patient is ventilated with a low tidal volume, you increase tidal volume by 2 ml per kilogram to 8 ml per kilogram, and then if you have now a PPV of 11%, you can assume that the patient will respond to fluid administration. And believe me, this is very helpful. In my experience in COVID-19 ARDS patients, it was very helpful. You don't need cardiac output monitoring to do this, only a simple auto line. This is a recent meta-analysis published in Critical Care some weeks ago. In this meta-analysis coming from China, the authors pulled all the studies that were published about a tidal volume challenge, and they found a nice summary area under the rocker curve, 0.96, with a good combined sensitivity, 0.92, good combined specificity, 0.88. So it seems to work. More recently, with Ruishi in my unit and others, we tried to perform tidal volume challenge during prone position. As you know, many patients are prone during ARDS, and therefore we wanted to know if this tidal volume challenge can work in this particular condition. And this worked very well. This is the area in green, the area under the rocker for the change in PPV, pulse pressure variation, during tidal volume challenge, 0.94 for the area under the rock curve, compared it was better than the area under the rock curve for PPV at baseline before increasing tidal volume. But by the way, the prediction by PPV in this study is not bad, 0.85. Also, you can use the change of pulse pressure variation during passive leg raising. And this is what we did with Temistok Takeri, Xavier Monet, and others in my unit some years ago. We looked at the decrease in pulse pressure variation during passive leg raising for 30 seconds or 1 minute, and we show that a decrease in PPV during PLR was reliable to predict fluid responsiveness with an excellent area under the rock curve, 0.98 for the prediction. So, again, you don't need any cardiac output monitor to do this, just a simple auto line. The risk of lung edema also should be assessed before giving fluid. In this consensus paper of the European Society of Intensive Medicine, we said that in patients with shock, and associated severe ARDS, it is important to use some advanced hemodynamic monitoring technologies like either the PA catheter, you can measure PEP, or the transpulmonary thermodynamic technique, you can obtain the value of extraventricular water and pulmonary vascular permeability index. So what is better? PEP? In fact, if we go back to physiology, if you have a value of PEP of 12, for example, this can be associated with different values of lung water. So it is difficult to assess the risk of lung edema only using PEP. And this was confirmed by this study, published years ago, but they look at lung water on the y-axis and PEP on the x-axis. There was no correlation, and a value of 12 can be associated with different values of lung water. So it cannot reliably assess the risk of pulmonary edema. It is better to estimate directly lung water using some transpulmonary thermodilation devices. And this is a recent meta-analysis looking at the link between lung water and mortality. It was many studies were pulled in this meta-analysis by Francesco Gavelli and others. And as expected, the higher the lung water, the higher the risk of mortality. But also, these devices can provide the value of PVPI, which is a good marker of lung capillary leak. And it is interesting to see that it is also an independent predictor of mortality in this study we did with Mathieu Josviac and Xavier Bonnet in ARDS patients. And if you look at this cartoon, if you have a normal PVPI, for example, 2, if you increase capillary pressure with fluid, you have no lung edema. If you have an alteration of permeability with a high PVPI, you have a huge increase in lung water. So you can anticipate the risk of fluid administration if you look at the value of PVPI. And it is worst when PVPI is 6, of course. So these devices are useful for guiding fluid management, especially in patients with ARDS and septic shock, because they well assess the risk, the benefit-risk ratio of fluid infusion, PPV, SVV, tidal volume challenge, PLR, and expert occlusion test to predict the benefit, and lung water and PVPI for assessing lung tolerance to fluid infusion. And you can make the decision to start, to continue, or to stop fluid infusion. So my conclusion, before infusing fluids in patients with ARDS, please look at the fluid infusion benefit-risk ratio, the benefit assessed by fluid responsiveness markers, the risk by markers of risk of lung edema, and this should be assessed patient per patient. Thank you very much.
Okay, this time for one question from the audience, please.
Marcelo.
Marcelo again. You want to be famous, Marcelo?
No, it's a very simple question, Jean-Louis. So how much were the average value for a very bad COVID patient? Did you have some idea how much was the extravascular lung water and permeability index, the average?
Yes, we published a paper about this in Critical Care in 2021 with Ruishi. The worst values are around 30, 35 ml per kilogram. The normal value is less than 10. But we had some patients with 15, 18, 20, and this is very important to know because sometimes you can hesitate before giving fluid. If you look at the value, so if you look at the PVPI value, you can or not give fluid. But when you have 35 with a high PVPI, it is better to not to give. Yeah.
In absence of thermodilation, can we use lung ultrasound as a surrogate marker?
You can use lung ultrasound. The issue is that in this kind of patients, you have already a lot of B lines. So it is difficult to differentiate this is a more semi-quantitative assessment than a quantitative assessment. But if you have no transpulmonary thermodilation, yes, you can use lung ultrasound and B line score to assess the risk of giving fluid, of course, yes.
Okay, I think, thank you very much.
Thank you.
Our next speaker, Stephen Pastoris from Weill Cornell, New York, on corticosteroids and ARDS.
Thank you, Gordon and Jesus, for getting the opportunity to talk. Outside of balanced versus unbalanced crystalloids, colloid versus crystalloids, corticosteroids are probably the most controversial pharmacologic agent. Would you agree? Yes. Just by quick show of hands, how many of you use corticosteroids for ARDS from pneumonia or sepsis, septic shock? Just by show of hands. I only have to talk for 5 minutes. I don't need to convince you. But I'm going to try that it's all about the right dose, the right time, and the right duration. Not so much the type of corticosteroid. You can use methylprednisolone, you can use dexamethasone, and I'm going to try to convince you it's these 3 other parameters that you have to take in mind. One important disclosure. So I have been part of the corticosteroid guideline writing for the last 16, 17 years. The last guideline was published in 2017 simultaneously in intensive care medicine and critical care medicine. We are currently in the process of updating the focus guideline for the use of steroids in sepsis, septic shock, ARDS, and community-acquired pneumonia. So stay tuned. If I get invited next year, maybe I'll present it then. So, but my views here are my personal views, and they're not the views of the panel, because we still have to conduct the voting and the finalization of the strength and evidence profiles. Just by way of rationale, I don't think I need to convince you that ARDS is a severe inflammatory process. It's self-perpetuating, it can be persistent. I'm not talking about the patients who within 24 hours get off the ventilator. That's not ARDS to me, and as I'm sure to many of you. I'm talking about the sick patient with ARDS who's requiring intubation and mechanical ventilation that persists certainly for days or even weeks. There is ongoing activation of pro-inflammatory mediators, as you well know, and deficiency in glucocorticoid alpha receptors. Those conditions set up for a situation where you have insensitivity to endogenous corticosteroids and uncontrolled and ongoing inflammation. If you look at the lung-safe study from 6 years ago and look at the adjuvant therapies for ARDS, look at towards the bottom. High-dose steroids were used in only about 18% of the time. A little bit more in severe ARDS, a little bit less in mild ARDS. Fast forward, if you go to 2022, certainly with COVID and dexamethasone, recovery, Dr. Villar's study, I think if we did this survey again, that number would probably be much higher now. So I mentioned the central questions when we think about corticosteroids in ARDS, or even in sepsis or severe community-acquired pneumonia. We can talk about the type of corticosteroids. We can talk about dosing. Are you favoring low, moderate, or high dose? Should you use it early? What's late? And whether you're using it for short or prolonged duration. It's important to recognize that all corticosteroids are not equivalent. They're not equivalent. So if you look at hydrocortisone as our measure for both glucocorticoid and mineralocorticoid activity, you will see that dexamethasone and bechamethasone, DEXA in particular, has the most glucocorticoid activity, but it has no mineralocorticoid activity. Methylprednisolone has more glucocorticoid activity and very little mineralocorticoid, and hydrocortisone is what we generally use in patients with septic shock, for example, because it has more of those additional properties. When you look at dosing of corticosteroids, you need to remember the effects, the genomic effects and the non-genomic effects, depending on the dose. If you're on the lower dose, and I'm just going to call low doses, low moderate doses at 0.5 to 2.5 mg per kilogram per day, you're going to have genomic effects. That's what you want. You want those effects that increase gene transcription of anti-inflammatory molecules and therefore inhibiting pro-inflammatory mediators, especially the transcriptor protein NF-kappa B, which, as you know, regulates the production of TNF and all the other bad cytokines out there. At very, very high doses, however, and I'm talking grams, let's say, of methylprednisolone, you now are talking about steroids acting at cell surface receptors, and you're now promoting non-genomic effects. And that will generally result in rapid neutrophil degranulation, which is commonly what we see in patients. On steroids, they have very, very high white blood cell counts. As I mentioned, in 2017, we published the updated guidelines from 2008. And during that time, we came up with the following recommendations. We suggested the use of methylprednisolone. At the time, the reason we were favoring methylprednisolone, because as you know, compared to the other corticosteroids, methylprednisolone penetrates into lung tissue a lot better, and it resides longer in the lung, which is why methylprednisolone is the favored anti-inflammatory steroid in many of the pneumonitis and other diseases that we see related to the lungs. We indicated the use of methylprednisolone at the time 1 mg per kilogram per day intravenously in patients with moderate to severe ARDS, PF less than 200, giving it within the first 72 hours of established diagnosis of ARDS. At the time, we gave this a conditional recommendation with moderate quality of evidence. Conditional because there were a lot of imprecision based on very small numbers of patients that were enrolled in the RCTs that we reviewed at the time. We suggested that for unresolving ARDS, that you can go up to 2 mg per kilogram per day, again, with a conditional or weak recommendation based on moderate quality of evidence. This was the recommended dosing regimen that we had in that guideline, a prolonged course. We said stick with 1 mg per kilogram per day for the first 2 weeks, and then cut that in half in the 3rd week, and then try to taper off by the 4th week. So we had suggested a prolonged regimen because we felt that there was persistent inflammation that was going on that justified a longer use of steroids, and the fact that the concern was if you were to cut out using steroids very quickly, you would have that rebound phenomenon. You didn't want to have to do that. So among adults with early and late unresolving ARDS, we recommended, in addition to using corticosteroids, that you measure CRP or the lung injury score in monitoring these patients, have a high degree of infection surveillance, so you're making sure you're picking up infections, including opportunistic infections. And the only concern that we had was hyperglycemia, which, as you know, is almost always a result of using corticosteroid therapy. But at the time, we did not find any increased risk of neuromuscular weakness, GI bleeding, or superinfection. Long-held concerns with use of high-dose steroids. The Cochrane review came out 2 years after we published our guideline, and it concluded pretty much with low certainty evidence that corticosteroids reduced the number of days on mechanical ventilation, i.e. ventilator-free days, were longer on corticosteroid therapy, but they were unable to draw firm conclusions about mortality or other outcomes. Fast forward to 2020, and our moderator, Dr. Billar, published the DEXA-ARDS study. And I believe this was a game changer. And this came out about 2 months or so before we all got hit in New York with the bad COVID pandemic. In the DEXA-ARDS study, they studied 277 patients. The study took 6 years to complete. They studied patients with moderate to severe ARDS, PF 200 or less, on PEEP of 10 after 24 hours. So they actually enriched the population by excluding those that rapidly resolved their respiratory failure, maybe got off the ventilator. Those were not the patients here. These were patients that were intubated, mechanically ventilated, PF less than 200, PEEP of 10, and persisting beyond 24 hours. They received dexamethasone in the intervention arm, 20 mg IV daily for the first 5 days, and then cut it down to 10 mg daily for days 6 to 10, unless the patients got extubated, at which point the dexamethasone was stopped. What they found was pretty amazing. They found, similar to the previous studies, that the duration of mechanical ventilation, mean of about 6 days, fell significantly on the DEXA arm, and all-cause mortality when looked at 60 days. Similarly, they did not find any increased rates of hyperglycemia, nosocomial infection, or barotrauma. Again, the results, as you know, were published in Lancet Respiratory Medicine. I tried to look at what systematic review and meta-analysis before I came to this Congress, and I found this in BMC Respiratory Research, just published, I think, in November of last year, that pulled 14 RCTs involving about 1,600 patients. And as you can see, the mortality that they found difference, 34.2% in the steroid arm versus 45.4%. Again, you can see the forest plot favoring the arm of corticosteroids. When they looked at the type of corticosteroids, they did not really find much difference whether the choice of corticosteroid was methylprednisolone, which was used in 7 RCTs, versus hydrocortisone in 4 RCTs. They both showed reduction in 28-day mortality. Important caveat, though, was that these analyses were done primarily on non-COVID ARDS patients. When they looked at duration, it didn't seem to matter whether steroid use was less than 7 days, 8 to 14 days, or even greater than 15 days. When they looked, however, at the low-dose methylpred versus the high-dose methylpred, they found that the low dose was associated with lower mortality as compared to the high dose. We did our own systematic review with Depayan Choudhary and McMaster, University of Toronto, published in Intensive Care Medicine in late 2021. We looked at 18 RCTs involving 2,800 patients. This is the largest comprehensive analysis of ARDS for COVID and non-COVID ARDS. 12 of the RCTs used the Berlin definition, 6 used COVID-19 ARDS patients. We found that corticosteroids probably reduce mortality in ARDS of any etiology, COVID, non-COVID, and the number to treat was 12.5. We found that in all patients who were critically ill with ARDS, corticosteroids reduce ICU mortality, probably reduce hospital mortality, and subgroup analysis did not show COVID status, steroid type, dosage, initiation time did not seem to show any credible subgroup effects. We found that the longer course, greater than 7 days, had higher rates of survival compared to the shorter courses. We also noted that the use of corticosteroids, again, patient-centered outcomes are very important. If you're only looking at mortality, of course, that's always what we like to see. But however, patient-centered mortality is like reduced duration of mechanical ventilation, shorter length of stay in the ICU in the hospital, I think, are very important patient-centered outcomes as well. We found uncertain effect on length of stay in the ICU, neuromuscular weakness, and GI bleeding, and probably an increase in hyperglycemia. The problem is that we don't have long-term outcome studies with steroids to detect if myopathy, which I think is a real phenomenon and can be certainly a concern because it can reduce quality of life, but we don't have those studies right now to look at as to the relationship of corticosteroid use and the prolonged incidence of neuromuscular weakness. So we pooled all of these studies, and Maduri published in 2021 this nice graph showing again that prolonged corticosteroid therapy, looking at about 1,000 patients, you can see duration of mechanical ventilation and ventilator dependence were all reduced in the patients that got corticosteroid therapy. I like this framework for initiating steroids. So if you have a very strong indication to use steroids, and that's on the top left of this panel, and the complication rate that you anticipate is going to be very low, of course, you should use steroids in those patients. However, if your indication for using steroids are not very, very strong, and you have a high risk of complications, then do not give steroids. But if you're somewhere in the middle, I think you have to do case-by-case, individualized management of these patients. And I know there's been a lot of talk about phenotyping, endotyping, and it's true. I think we're going to get there. I think there's some studies showing that certainly there are some phenotypes and genotypes that can be detected that may determine which patients may respond better or not to corticosteroid therapy. So I'm just going to conclude that in terms of type of steroid, there is no differential effect based on steroid type. So whether you use methylpred or dexamethasone is fine. I go with the 1 milligram per kilogram per day after an initial bolus, and I always give a bolus because I want to saturate those receptors as quickly as possible, and then I go to the 1 mg per kilogram per day. If you're using dexamethasone, generally I would adhere to the DEXA ARDS study, 20 IV dex taper to 10 and cut out if the patient is extubated. Use early, I would say between 48 and 72 hours ideally, and the longer course, at least 10 days with a slow taper to prevent the rebound. So if you're still in doubt whether you're going to use corticosteroids for ARDS, I would say just do it. Thank you.
Okay, now the presentation is open for questions from the audience, and I hope people will ask some questions to the speaker.
Pneumonia causing ARDS. In that case, within 72 hours, are you going to start steroid?
You might do it early. That was just sort of like a range, but in a severe case, I would initiate it as early as possible.
Even with pneumonia?
Yes, pneumonia with ARDS.
Yeah.
Yes, yes.
In survivable sepsis guideline, in sepsis with ARDS, they haven't recommended steroid, with high recommendation. They haven't given. So it seems that from your study and others, it's quite effective. So do you think that it should come into the guideline?
Yes, I think we will be very explicit in stating that when we refer to just pneumonia with garden variety sepsis, that would not be the situation there. But in patients with septic shock from pneumonia with ARDS, that would be the situation to consider steroids. Okay. But if you're just talking plain pneumonia with sepsis but not septic shock, then that would be a situation where, unless it's severe community-acquired pneumonia, that would not be the situation to initiate steroids.
Thank you.
Leo Bos from Amsterdam. Nice presentation, thank you. For those who are not inherent enthusiasts about corticosteroids in ARDS, there are quite some methodological concerns with most of the trials, either in the number of patients that were enrolled in the time frame that the trial was executed, or the selection of patients that was quite unclear what criteria were used to put the patient into the study or not. What is the path forward towards a more general acceptance of steroid use by people who are maybe still not overly enthusiastic based on the evidence that...
Yeah, it's true. As I mentioned, the recommendations have largely remained conditional or weak and not strong recommendations, largely because the RCTs to date have been compounded by a lot of serious limitations, as I mentioned, imprecision, small numbers of patients in some trials, inclusion-exclusion criteria. There are some issues there. I think except for Dr. Villar's study that was really much more homogeneous, I think all the other studies were problematic. So if I were to move forward with this, I think selection of patients is key, what parameter to use. I'm really hoping that we get to that next stage of just identifying the subphenotypes and endotypes for the patients that we can determine who might get harmed with steroids. I'm not saying steroids should be used for everybody with ARDS, but I think we have to be more selective. But until those studies are out, it's been hard to make a strong recommendation for steroids in ARDS,
Stephen,
just as a blanket statement.
I think, questioner, I think your questions were relating to the, if I'm not mistaken, I think we have the author with the trial of the questions you were raising, or no, am I wrong?
So they relate to all the studies, but
okay.
Also in the fantastic study of Jesus, there was an important concern that the study was stopped because recruitment was slow, right? And this is, per definition, an indication that it is not a general recommendation for any ARDS patient, because if the study recruits slow, that means these patients are very, very rare. Right, Jesus?
Yeah. Well, it's because we did prognostic enrichment and end up by excluding many patients. Many patients that by their self, they improve and were extubated.
But I think this is, this is such a key point about Jesus's trial. And one of the important lessons he's taught us from his studies where we intubate patients and put them on standardized ventilation is the patients who no longer meet ARDS criteria with a minimal amount of PEEP and some standardized ventilator settings. You've identified a group of patients who are really very sick and are going to be ventilated for a while. Yeah. So I just think that this is such an important part of both the design of the study and for the selection, and Stephen mentioned it, but I think for all of you who are, getting used to treating patients on high flow nasal oxygen with COVID with steroids, the community-acquired pneumonia patients that we're talking about here are very, very different than the COVID patients. I don't want to, Steve, if you disagree with me, then, because I think as a group of doctors, we've gotten used to now using dexamethasone on patients with COVID who don't look very sick, right? Because these are patients that have been studied for trials. But the community-acquired pneumonia patients that are, intubated, I don't know how to apply, maybe Jesus does, I don't know how to apply the DEXA data to a community-acquired pneumonia patient who's on high flow. Do you?
Yeah, no, I agree with you. A lot of the problems with the RCTs that were done, some of them that were reviewed in the systematic reviews and meta-analysis actually were patients that were enrolled in trials that did not do lung protective ventilation. I think Dr. Villar's study, actually, all patients were on protective lung ventilation. So if you put that into some context, I think you really have to do a trial that really already uses optimal ventilatory management, and then you're doing an intervention to see if that makes it.
Yeah, I mean, the Scandinavian people did the COVID-2 study, and they include patients as of course, this was only on COVID. But they include patients requiring oxygen and high flow cannula, Gordon, and only among almost 1,000 patients, they only include 200 patients requiring mechanical ventilation. So it's a mix that you don't. I mean, it's impossible to say one word about that study because it's a mix of patients. Of course, only with one cause, COVID. But they didn't do any prognostic enrichment. They didn't do any predictive enrichment. They didn't do anything, just based on baseline criteria.
Yep. I mean, ARDS trials are hard. I mean, I think there was one comment about it. It took a long time. Well, the ArdsNet trial took a long time. The Lazarus trial actually had to stop because it was just challenging. We might think ARDS is very, very common, but I'm not sure it's that common enough that you can just enroll patients, every day in your ICU in a clinical trial. But certainly it's something that we need to keep doing is we need to do clinical trials, and we need to I think we've gotten better, but if you don't control for certain variables, then you're just not going to get the result of whatever you're trying to do. Is there time? There's one more question. Yeah. Thank you.
I have a practical question. You mentioned hyperglycemia, and usually when you split a daily dose into 2 doses, glucose control becomes much more easy. Are there any drawbacks for that strategy?
Yeah, no, I almost always also split the dose, whether I'm using 60 or 70 milligrams of methylprednisolone, for example, I usually split it in divided doses. The other way to do it is, of course, if you're doing a continuous infusion, glycemic control is much better when you do continuous infusion. It's not so much popular in the US. We still do divided doses or once daily doses of methylprednisolone, but in those centers that may use other agents like hydrocortisone, for example, if that's what you happen to use, then the continuous infusion does appear to show more steady glycemic control. So yes.
Thank you.
Great. That was thank you very much.
Thank you.
Thank you very much.
So I'll introduce and then you discuss.
Yes.
Okay. Okay.
So only 3 more lectures to finish this session. Please stay in the room. The next speaker is Paul Mayo from New York. He is going to talk about the utility of lung ultrasonography in ARDS. Thank you.
Good afternoon. I come from the New York City area. I have no relevant disclosures to make. And I will convince you, I hope, that lung ultrasound, we'll call it LUS and ARDS, there are several utilities that you might consider in your clinical practice. For example, you might be able to entirely replace chest film with LUS to fulfill the imaging requirements for the diagnosis. You might be able to prognosticate, depending on the severity of the involvement with LUS, and perhaps we could classify the disease pattern as either focal or diffuse, which might predict response to PEEP or prone position. And finally, we know our patients with ARDS are unstable in many other ways, so I will try to promote the idea of rapid point of care ultrasonography, WUBU, whole body ultrasonography, to be deployed immediately with any decompensation of the patient who has ARDS. How about for simple identification of a pattern that would be consistent with ARDS? Now, everyone in this room agrees that lung ultrasound, chest film, chest CT in isolation cannot diagnose ARDS. It just shows abnormality. So therefore, findings are always nonspecific until the clinician puts in a little clinical correlation, right? PF ratio, the clinical background of the patient as they present, et cetera, et cetera. And although CT has been used for this purpose, we know it's a completely impractical gold standard. Chest X-ray, therefore, is proposed in the Berlin definition as a bailout. That's how we're going to define the disease, with a chest film, frequently supine, rotated, under or over penetrated, which consists of an indecipherable summation artifact of whiteness. It is not a three-dimensional technique, it's a two-dimensional summation technique. And yet chest film has been required, is the go-to for the Berlin definition. So how does LUS compare to chest X-ray? In fact, could it replace chest X-ray as the primary definitional imaging modality for ARDS, providing you have the correct clinical presentation? So how does LUS actually compare, not to chest films, but to CT scan for this application? We turn to classic literature. Dr. Lichtenstein was the first LUS guy to compare using CT as gold standard, chest film and LUS. And he found that LUS was far superior when compared to CT scan for identification of all of the findings that are relevant to us in this room. Pneumothorax, normal aeration pattern, interstitial abnormality, consolidation, pleural effusion were better identified with excellent correlation with CT than with chest films. Zidochaki, who comes from Crete, basically repeated this and found the same thing, that X-rays have minimal utility compared to LUS, if the team is capable when compared to CT. And then of interest to the frugal intensivist in a under-resourced area, LUS basically just puts chest films out of business, okay? So once more, LUS is not an answer for all our questions, but it's really effective for the questions you address on a daily basis in the ICU, including, does the patient have ARDS? So the reason I think that LUS has not formally replaced this in any new definition is the Berlin definition was developed in the pre-LUS era. And of course, all of you are aware of the interesting Kigali proposal, of which there's some literature here, where in Kigali, under-resourced area, the proposal is that LUS replaces chest films because they don't even have access to chest films in these areas, okay? Ultrasound is portable, cheap, repeatable, et cetera, et cetera. So this is of particular interest to clinicians in these areas who have to use a frugal solution to everything they do. But Dr. Mekontso Dessap, in a great editorial in intensive care, reminds us that the frugal intensivist approach is easily and appropriately adaptable to the over-resourced area where we live, right? So, what are the findings that would clue you into replacing chest film with LUS consistent with ARDS findings? And I want you to look at these two articles. They're from a great Amsterdam group, and there's a lot of information about this, but they sort of formally describe the patterns that you see with interstitial abnormality, pleural findings consistent with ARDS, and without going into too much detail, we start, I wonder how we activate these. I don't want to lose the image. On the left, we have a bunch of B lines. On the second, we have a little bit of small consolidation. Then we have irregular pleural surface, more irregularity. And if you find these all over the place in a patient with a correct clinical presentation, I guarantee you the CT will show extensive interstitial changes consistent with ARDS, and the chest film becomes irrelevant. Now, please, please be reminded that the LUS findings of interstitial abnormalities, small consolidation, have plenty of other causes, CHF, all the interstitial lung diseases, pneumoconiosis, lymphangitic carcinoma. Always clinical correlation is required, just as with the Berlin definition, right? So other criteria for ARDS must be made. Let me advance this. Oh, look, they move. Oh, there we go. So B lines, small consolidation pattern, a lot of irregularity. And the Amsterdam group, I think I saw Dr. Boss here in the audience, maybe, yeah. He would say, you know, that pleural looks fragmented, irregular, and thickened. They've developed for the first time formal criteria for making these measurements. It's not just an eyeball call. So I propose lung ultrasound should replace chest film. We'll see what the next consensus statement comes out with. Now, what about prognosis once you've used LUS with other clinical criteria to render diagnosis of ARDS? Could the prognosis of the disease be somewhat determined? And LUS, chest film, chest CT, the more involvement, the more progressive the involvement is, the worse the prognosis. I mean, that's almost commonsensical in statement. And this has been looked at, and in fact, if you have a lot of abnormality in LUS, and if it progresses day after day after day, the prognosis of this patient is not as good as if it's less and is getting better, right? And of course, all of you who were working in the COVID surge units understood that as the person got sicker, their LUS findings got worse. And that has been examined for prognostic statement, okay? Now, what about the interesting possibility that there might actually be management strategy that could evolve from LUS findings as they've evolved from CT? So, do these move? No, they don't move. So, here we have two classic CT patterns, well-defined 20 years ago, right? Where you have generalized ARDS, and then on the right, where I have the probes there looking, You have relatively normal aeration pattern, maybe with a few little belets, but the disease is highly, highly geographic and dependent in position. And right away, I guess we would start to think, might this help us in terms of planning your management strategy? And first of all, we know through the early work of Dr. Rouby, Jean-Jacques Rouby's group, that if you apply PEEP to ARDS, you can see evidence of re-aeration, but they're very careful. You can't define whether hyperinflation has occurred, okay? So then Dr. Pratt said, hey, maybe you could predict prone position response. And there are 2 studies that seem to indicate that that's the case. On the con side, not so convincing. And there's a nice editorial there at the bottom where it discusses the problem. So this is a bit unknown. I happen to favor that it does help in predicting response for oxygenation function. Does it predict response to survival? No, but it's an interesting proposal, all right? So we'll say clinical equipoise probably applies, except I'm a believer that if we see a lot of dependent consolidation pattern, we flip them over before we call a failure point for ECMO, all right? And we're much less enthusiastic if it's generalized disease. What are some other utilities of LUS for ARDS? Well, all of us who were sequestered in those hot, noisy surge units, we saw people who dropped lung, who developed progressive, severe acute cor pulmonale pattern because of lung disease, vascular disease, and this is where LUS must be combined with the ability to have urgent reevaluation of the patient who's having decompensation, hemodynamic or respiratory. The number of patients where we were able to identify pneumothorax literally within a minute or 2 is in the scores in my surge units. The utility for cardiac management, looking for DVTs with hypercoagulable states, all of these are just obvious. So LUS, although that's what we're talking about, I'll recommend that you think about it in terms of a general approach to the patient. So my opinion is that it should replace chest film for the in the new wherever the city's going to be, Kigali or Berlin or Brussels definition. All right, I would defend that position very strongly. In terms of prognostic statement, that's a simple-minded thing. If you see on any imaging modality, the ARDS pattern get worse and worse and worse, the prognosis is worse and worse and worse. The jury is a bit out for prediction of recruitment effect, but please consider that as a possibility. And then always combine LUS with other parts of whole body ultrasonography, particularly in the urgent response to cardiopulmonary failure in these patients who are already on ventilators, immediately, serially, in goal-directed fashion. There are a few controversies. The academic centers who are doing a lot of research, they need to score the degree of involvement with lung ultrasound in patients with ARDS, so they have 12-zone approach. There was an 8-zone that was, but the 12-zone developed by Jean-Jacques Rouby is now pretty much considered the go-to. Do you or I, who are not involved with research, we're involved with keeping people alive, I would not recommend the need for formal scoring. Rather, use the probe in a logical linear, line approach, always trying to get a posterior view by tipping the patient a little bit to the side. Watch the endotracheal tube when that's done to get a look-see for pattern posterior. Is there a need for update to the Berlin definition? Yeah, definitely. Is it right to propose LUS instead of chest film? Absolutely. And then LUS and whole body ultrasound, we're aware that volume overload is not to the benefit of these patients. So there's very interesting work on that, and that involves echocardiography and so-called VEXAS scoring, or its analog for management of ARDS. 8, 7, 6, 5, yes. All right. Shall we wait for questions at the end?
No, we'll do them now.
Oh, whoa, okay, all right, good.
Well, let me start out and just say that I'm not sure that you're saying anything revolutionary by proposing lung ultrasound to replace the X-ray. Here's your problem. The diagnosis of ARDS per se at the bedside, everybody agrees, since we don't actually have a treatment for it, it's not actually that clinically relevant. It is, however, relevant for researchers. By the way, we researchers like to keep people alive as well. So the problem you have is the challenge with the X-ray is reliability. It's agreement. And the challenge in showing that the lung ultrasound is improved in terms of reliability, since you have both a skill involved in ascertaining the images and a skill in interpreting the instruments. How do you do this study to show that the clinician diagnosing, ascertaining ARDS at the bedside in New York City does the same as she does in Brussels? How do you do that study? Because you can't just take the images and show them to people and say, do you agree that there are B lines here?
So this is where the work from the Amsterdam group is so important, that they have, they're approaching the point where there's more formal possibility of scoring system, et cetera, et cetera. I think it's a point well taken. Why replace something that might work with something?
No, it doesn't work. No, excuse me. No, the chest X-ray is horrible when it comes to reliability. We know that.
All right.
So you could just argue that anything's better than horrible, and I might be persuaded by that. But that's your goal. That's what you have to overcome. Showing that the lung ultrasound is as good as CT scan in the hands of very good people or in the people they train is really interesting. It doesn't fix the problem.
Only training will fix the problem. And widespread use of ultrasound in well-trained hands, that's the goal. But I agree, if a person doesn't know how to use the ultrasound probe and does not interpret the image, it's not going to have a lot of utility.
I can tell you that all the people who've participated in this studies who were interpreting X-rays for ARDS, they were all great. They all thought they were great, and they were all great. So it's not just a matter of training and people who think they're great. We've got to, you got to do the...
Absolutely. So as a point of interest, the ACGME RRC committee has now recommended all forms of critical ultrasound as required for fellowship training in the United States. So we'll have an answer to your concern, which is a major concern, in about 3 years, because every fellow that comes out of training will be fully trained, now that there's a requirement for that. Okay, we hope. Okay?
Yep.
Some other questions, sir?
Paul, I need your help. I live in a beautiful country, Italy, when the CT scan was the gold standard for ARDS. At the moment, I think there is a schism between physicians who believe in ARDS and don't do lung ultrasound. Because I never consider to modify my ventilator over ACT perform 48 hours before. I need to check my lung and to set PEEP or do recruitment maneuver or lung ultrasound. We do the study you present in prone position. So I think the Bruxelles definition for, we need to put lung ultrasound in ARDS definition. It is a time for that.
With the caution from our moderator, right? The schism is very interesting. There was an editorial fight about that in ICM, I remember. It was sort of a north-south a little bit schism. I hope it's been resolved.
Second, and I finish, I think we need to cancel chest X-rays. Chest X-rays is economical, and is a ionized radiation for patients. It is not informative, not informative. Chest X-rays lose several times with the lung ultrasound. Thank you.
Dr. Boss, oh yes, we're running, we don't want to run over time.
I have a short question. Do you recommend to use ultrasound every day or only at the beginning? How can we follow our patients or when the things go worse?
My personal recommendation is what we do every day in my ICU. We have a couple of ultrasound machines. The ultrasound machine is always with us on morning rounds. Anybody on a ventilator, it's not even a thought, gets a full LUS by line technique, absolutely. That would replace the old-fashioned method where when I was in training, you did a chest film every day. Why would you do that? Do lung ultrasound. So if you have the capability, do it every day. Do it twice a day. Lung ultrasonography is free as the air that we breathe, okay?
Yes, thank you.
All right, yeah. Dr. Boss, who's from the Amsterdam group, we've run out of time, but
I don't have to introduce.
Is he allowed a question?
But I fully agree with Gordon Rubenfeld on this, because I think what we have a problem with ultrasound is that there is a large group of people who is very enthusiastic and who starts doing it at the bedside. And there's not a lot of evidence in favor of the diagnostic accuracy in many circumstances. And we all come up with our own terminologies and definitions. So I would argue if we move in the direction of including this in criteria, that we do 12-zone scores. We do store our videos that we make all in exactly the same way, and that we do evaluate the same clips all around the world and come to a consensus that this is what we call B1, this is what we call B2, and this is what we call a subpleural consolidation. In the end, before you can do this on the other side of the world, we need to talk the same language.
Right.
And I think the time has come that we start doing it, especially because we are now starting to do randomized controlled trials where lung ultrasound is the entry criteria. We are doing a trial, Pegasus trial, where we're trying to validate these focal, non-focal approaches. And it means that we're going to change the management of the patient based on what we see on the ultrasound. And we need to be sure that we all mean the same
So
thing.
how about this? We'll negotiate a settlement. For initial diagnosis, there must be a 12-zone score, and your work is now defining the findings in a more formal way, which is why it's so important. Okay?
Thank you. I'll take that consensus.
Okay, thank you very much. Very interesting. Okay, 2 lectures more to go. Now the speaker is Emma Bowcock. She is from Kingswood, Australia, and is going to talk about the ECHO, is the non-invasive pulmonary artery catheter.
Thank you very much. I'd like to extend my thanks to the organisers for asking me to speak on this topic. I didn't realise how bright these lights would be. I can hardly see anyone, but okay. So this talk is ECHO is the non-invasive SWAN. I have no conflicts of interest. Of course, with an invasive PA catheter, we can get direct measurements of right atrial pressures and pulmonary artery systolic mean and diastolic pressures, as well as pulmonary artery occlusion pressure, and then we can derive pulmonary vascular resistance and use thermodilution to measure cardiac output. But unfortunately, in a lot of our patients with ARDS, we don't have PA catheters in. And therefore, I hope to show you in this whistle-stop tour over the next 15 minutes about the utility of echocardiography, that we can use ECHO as a non-invasive SWAN to make this journey through the transpulmonary circuit, and really to help us try to extend our clinical examination to get answers to clinically relevant questions at the bedside for our patients. I want to say, I think up front and center, that ECHO cannot replace a PA catheter, but it does provide really crucial structural information, I think particularly with regards to the right ventricle and the status of the pulmonary circulation in these patient groups. I think we could use, and as Antoine Viard-Baron's mentioned in the state-of-the-art paper in 2018, that we can perhaps use echo to identify that subgroup of patients with ARDS that could benefit from a PA catheter. And of course, no hemodynamic tool is perfect, and echo has many, many pitfalls. And I'm going to emphasize these throughout this talk because I think we need to get more comfortable working with echocardiography in that gray zone, because these are the patients that we deal with every day. So at the bedside, how does echocardiography help me navigate this transpulmonary circuit and answer clinically relevant questions to help me target my management? Well, I like to know whether there's raised right atrial pressures, if there's evidence of systemic venous congestion, and whether there's right to left shunting. I want to know if my patient has pulmonary hypertension and if they have right ventricular injury. I want to assess the status of their pulmonary vasculature as best we can, which is not perfect with echo, but do they have raised pulmonary vascular resistance? And then moving on to the left side of the heart. And importantly, we know that there's overlap with cardiogenic and non-cardiogenic pulmonary edema and ARDS, and it's important that we recognize these patients and identify whether there is raised left atrial pressures. And of course, fundamental to all of this is what's the cardiac output and how is that trending with my patient. So, of course, ARDS patients are often the most complex patients we deal with in the ICU. They're a very heterogeneous group, and they're on a dynamic cardiovascular journey. And I think echo as an extension of our clinical examination is important for us to trend this journey. Echo helps us in the emergency salvage situations where we have significant escalation in pressure requirements and things like that. But I also think it really helps us in fine-tuning our management as well. But I think most crucially, echocardiography allows us to assess the response to our targeted treatments at the bedside and to know whether these are working or not and whether we need to change our strategies. And I think it has a very important role in future research studies as we better try to subtype patients with ARDS, and can we identify particular subgroups that could benefit most from particular treatment strategies and help improve that signal-to-noise ratio in future prospective research. So starting with the right atrium and estimates of right atrial pressure, well, we know that in spontaneously breathing patients, we can assess the size and the collapsibility of the inferior vena cava, and that gives us reasonable estimation of right atrial pressure. But of course, in mechanically ventilated patients with ARDS, that is really, goes out the window. It's really not helpful. But there are other things that we can look at that can really help us decide whether there's raised right atrial pressure, and also what's the cause of the raised right atrial pressure. If for those of you that went to Antoine Viard-Baron talk this morning on CVP, he talked about how it could be for raised right atrial pressure could either be from acute cor pulmonale RV failure, or from compression, from cardiac tamponade, or volume overload. And I think echo is really crucial to helping us define what the cause of the right atrial pressure rise is. So in this echo loop here, for those of you that do lots of echo in your clinical practice, this will be quite easy for you to spot, but a really crucial structural structure that's often overlooked is the intraatrial septum. And this is often described as the whistleblower between the left and the right atrium. So here we have the right atrium and the left atrium, and we can see that this intraatrial septum is fixed and it's bowed across to the left side. And this tells us that this patient has raised right atrial pressures. And also, as we look a little bit closer at the right heart, we can see this right heart is dilated and there's paradoxical septal motion, and this patient has acute cor pulmonale leading to their raised right atrial pressures. We know that around 20, from studies from Mekontso, Dessap, we know that around 20% of patients with moderate to severe ARDS have patent foramen ovales, and they right to left shunt across this. And we can do bubble studies with echocardiography. With agitated saline, and we can look for evidence of right to left shunt as bubbles move across from the right side to the left side within 3 cardiac cycles. We know that this patient has a right to left shunt, and often we need to do transesophageal echo for this, of course, but it's a really important patient group to identify because we know they're likely to be PEEP non-responders. We can use hepatic vein Doppler with pulse wave Doppler as important readouts for what's happening in the right atrium. There's a lot of interest now in VEXUS, and I'm not going to go into all of that, but I'm not an expert in it. But We can use pulse wave Doppler in through the hepatic vein, and in the normal patient, we get forward flow from the hepatic vein into the right atrium during systole and diastole. And that flow is predominant, and I hope in all of us in this room, in systole. And as the atria contracts, we get this atrial reversal wave of blood going back into the hepatic vein. And we can use the relationship of this systolic to diastolic wave to give us an estimate, really, of what the right atrial pressure is doing. But I think key to all of this is the trending in the individual patient. And like any measurement with flow and Doppler, there are caveats with that, and the effects of mechanical ventilation, the effects of arrhythmias, and of course any constraining effects on the pericardium, such as in constrictive pericarditis. Of course, we're going to get diastolic flow reversals, and so this can be messed up and we can't use it. But generally, if we trend it in the individual patient, it's helpful. And of course, if we see patterns like this, which is a really ominous pattern, it's systolic flow reversal. We can see here that the systolic flow is now above the baseline. It's refluxing back into that hepatic vein, telling us that we've got significant hepatic congestion. And we know that these patients are in real trouble unless we instigate treatment strategies pretty quickly. So moving on to the pulmonary circulation, is there pulmonary hypertension? We can use the tricuspid regurgitant jet for this using continuous wave Doppler, and we use a simplified Bernoulli equation, which I'm sure you're all familiar with, where we use the tricuspid regurgitant maximal velocity. We can see here in this patient it's around 4.6, and we square that and times it by 4 and add on the right atrial pressure. And this gives us reasonable estimates of what the pulmonary artery systolic pressure is. Again, pitfalls with patients that this is a patient with severe tricuspid regurgitation. This is the right ventricle, right atrium. And we know that in this patient group, we're going to significantly underestimate our pulmonary pressures because we get rapid equalization between the right ventricle and the right atrium. And we get what's called the V cutoff sign. And that's analogous to the V wave that we would see on our CVP tracing. And of course, again, respiratory variation, arrhythmias, etc., are going to be reducing the accuracy of all of these measurements. We can look at the pulmonary regurgitant jet in many different windows with echocardiography or with transesophageal, and we can get, using continuous wave Doppler again, we can get flow profiles that look something like this, where we use the maximal PR velocity, and again, using the simplified Bernoulli equation, this gives us an estimate of mean pulmonary artery pressure. We can use end diastolic velocities to get estimates of diastolic pulmonary artery pressure. But for those of you that do echocardiography routinely, you'll know that this textbook continuous Doppler profile isn't what we get. We get something usually that looks a little more like this, and it's hard to know exactly where to put your pointer to measure these pressures. And Pablo Mercado, Michelle Slamer's group in 2018 looked at simultaneous Doppler versus echo Doppler versus PA catheter measurements of tricuspid regurg and pulmonary pressures in 40 patients that were all mechanically ventilated. And they found that it was had good accuracy and good precision, but unfortunately it was only obtainable in 60% of patients, which was slightly less than what had been previously reported. And that pulmonary regurgitant signal was only available in around a fifth of patients, and it had no correlation with mean or diastolic pressures. So I think particularly useful in our patient group is assessment of what's happening in the right ventricular outflow tract, and this gives us a window, as I like, into the soul of the pulmonary circulation. And the question that we really care about is there raised pulmonary vascular resistance, because we could potentially do something about this. And if we put pulse wave Doppler just behind that pulmonary valve that we can see here, this is called a modified subcostal view. We can use pulse wave Doppler to get nice spectral waveforms of the right ventricular outflow tract. Now, of course, we know from recent studies by Damassa and Mercado that we can't use the measurements such as the acceleration time, which is the time from onset of ejection to peak ejection, that acceleration time. We can't use that to infer pulmonary pressures, but we can use this acceleration time to tell us whether we're dealing with raised pulmonary vascular resistance. And in a Scandinavian study by Tosinova et al., they found that in close to 1,500 patients that the acceleration time emerged as the best discriminator for detecting significantly elevated pulmonary vascular resistance of more than 3 Wood units. and they had a cutoff value of less than 90 milliseconds. Of course, there are again caveats with heart rate and stroke volume, etc., that are going to affect this value, but again, the individual trend can be really helpful. And it's a lot harder to fake notching through the right ventricular outflow tract. And so if we're seeing profiles, that's often referred to as the flying W sign and notching, we can be pretty sure we're dealing with significantly elevated pulmonary vascular resistance. And we would be looking for other pathologies such as pulmonary emboli if we start seeing these profiles. So we know that, of course, in low cardiac output states that our pulmonary pressures often don't reflect the degree of pulmonary vascular dysfunction that we're dealing with. And in this patient with acute cor pulmonale and ARDS with this big dilated right ventricle, big dilated right atrium and paradoxical septal motion, the pulmonary pressures are quite low because the patient's not able to generate that. So I think by using the RVOT flow and pulmonary acceleration time, we really get a window into the status of the pulmonary vasculature, and combining these values of accel time of 55 alongside the assessment of the right ventricle, we get the idea that we're dealing with severe RV pulmonary circuit dysfunction. And we can then target our therapies, with earlier pulmonary vasodilators, with things that are going to improve RV performance and reduce pulmonary vascular resistance. And perhaps it's the trending of these parameters, that we can use to guide whether we've got recruitability in the pulmonary circulation and whether we're actually making a difference in the patient's hemodynamics at the bedside. In a sub-study of the FACT trial, back in 2010, Bull et al. Evaluated 475 patients, and they found that in patients that had this elevated transpulmonary gradients, that it was associated with higher 60-day mortality. And of course, it's difficult to know cause and effect, but it's still an interesting hypothesis. And I wonder if subgroups of patients with raised pulmonary vascular resistance and elevated transpulmonary gradients could be those subgroups that could benefit, particularly from agents such as inhaled nitric oxide earlier in the piece. This is a very busy slide, and I apologize for this. This is Greg Scalia's paper that evaluated the echocardiographic pulmonary to left arterial ratio in patients with pulmonary hypertension back in 2016, and they use a ratio that uses the tricuspid regurgitant velocity over the E to E prime, which is a non-invasive surrogate of left atrial pressure. And it's really a marker, a non-invasive marker of your transpulmonary gradient. And they were able to differentiate patients with reasonable accuracy in differentiating patients with pre- and post-capillary pulmonary hypertension. And essentially, as this EPLAR value gets higher, that signifies that we're dealing with raised transpulmonary gradients. And most recently, using the cutoff derived from the Scalia paper, Rende et al. In patients that were hospitalized for COVID-19 found that at admission, if patients had an EPLAR value of more than 2.8 meters per second, signifying raised TPG, that they had higher short-term mortality. And I think this warrants further investigation in our patient groups. So is there right ventricular injury? The million-dollar question, the prognostic question. We know that 20 to 30% of patients with moderate to severe ARDS will develop acute cor pulmonale, and it's maybe even higher, close to 50% in patients with severe ARDS, and that's in the era of lung protective ventilation. But we know that right ventricular injury is prognostic, and we know that we need to better define right ventricular injury in ARDS. And it's important with assessment of the right ventricle that we use multimodal strategies. We know we shouldn't use single values in isolation. And so using metrics such as the TAPSI and the right metrics of, and using serial assessments of right ventricular size and fractionary change, and perhaps, there's some studies looking at right ventricular strain, whether we can use all of these together to better define right ventricular phenotypes. And it will be interesting to see the emerging role of metrics that are assessing RVPA coupling, to see whether these can help us better define right ventricular injury in ARDS and help us better target our treatment strategies. And finally, moving on to the left side, that really difficult question is there raised left-sided filling pressures? And it's really quite difficult to answer this in most patients. In patients like this, it's easy because we have severe left ventricular systolic dysfunction. We have a really dilated left atrium, and instead of having that bowing to the left side. We now have fixed bowing to the right, and we know that this patient has raised left atrial pressure. And similarly, in patients like this one with severe mitral regurg, we're going to be dealing with a cardiogenic component to the pulmonary infiltrate. But unfortunately, most of our patients, they're in this gray zone, and I'm not going to, I'm way over time, so I'm going to skip through this. But essentially, we have this set of diastolic dysfunction guidelines that we can use to try and decide upon whether we have elevated left atrial pressures. And we talk through some of the caveats of all of these in a review article from last year. Michelle Slama's group serially assessed invasive pulmonary artery occlusion pressure against Doppler echocardiography and found that these American Society guidelines of diastolic dysfunction really didn't perform well in our patient group, and this was in 98 patients. And they proposed simpler techniques, and Landsper et al. Have also proposed simpler metrics. And I think simpler metrics are obviously key because we're all going to use them more, and they'll stop being a research tool and they'll become clinically useful at the bedside. And they found that in patients that had ejection fractions of less than or equal to 45, with an E to A ratio, which is the flow through the mitral inflow of more than 1.5, these patients were highly likely to have raised left atrial pressures, whereas patients that had normal ejection fraction above 45%, and lateral E primes of more than 8, they were highly likely, in fact 100% of the patients in this study had normal left atrial pressures. But of course, it's, identifying patients with raised left atrial pressure is really important. We can tip patients with maybe mild diastolic dysfunction into severe diastolic dysfunction with raised left atrial pressures with fluids. And it's important we identify these patients because we know if we give patients with raised left atrial pressure, pulmonary vasodilators, for example, we will worsen pulmonary edema. So, I skipped this last one. So in summary, echo is the non-invasive swan. It's imperfect, but I think it does allow us to trend the transpulmonary circuit and ask really clinically relevant questions. And of course, the clinical context is crucial. I don't think we're ever going to get away from pitfalls. I think we're always, to some extent, going to be working in the grey zone, and it's using echo within the parameters of this grey zone that really is the art and science of medicine. And I think echo is a really important tool that's going to allow us to stratify subgroups for future prospective study. And with that, I thank you very much for listening.
Yeah, we have time only for half a question, a very short question, because we are above the time. So nice presentation. Emma, but we have no time for work.
I think we should probably move on.
That's fine by me.
Okay.
Yeah, thank you.
Thank you. Okay, now the last talk by Sharon Einav from Jerusalem, Israel. She's going to talk about the utility of dual energy computed tomography imaging.
Those hardcore that are staying here, I hope that you enjoy this, because this is, I think, the science fiction of
yeah, to me,
medicine.
when I read the title, it looks like a science fiction.
It is, and I think it's you can see it in the slides. So I have no conflict of interest. I'm usually not very much interested in imaging, but this tool, I think, is a game changer. I'm going to explain a few words about dual energy CT and then run through a couple of other topics that I find particularly relevant to intensivists. So the basic principles of dual energy CT is the use of two energy levels rather than one. You can see here the conventional technology used which uses a single energy at 120 kilovolt. And then there is the dual energy technology, which uses two levels of energy and attenuation. The separation of specific materials, or what we use, what we call tissues, depends on the molecular weight of the material. Specific materials are more in a specific tissue, and the energy absorption characteristics of that material are used to distinguish them within the specific tissues. They have different interactions with different energy levels, and it's most striking with iodine, but not only iodine. For example, We are now learning that dual energy CT can separate between can identify uric acid, can also identify iron and fat, and I'll show you some of the uses that we put to use in my institute. After separating the material, you can either use that separation to enhance specific structures, and then you can quantify the amount of material that you have in there for various reasons I'll show you, or you can actually use that information to remove that finding from the CT. So I'll start with pulmonary blood volume. Dual energy CT is most commonly used for the diagnosis of pulmonary embolism, and what you can see here are the typical wedge-shaped finding. I think that to do that, I don't know how to do this. Never mind. And anyway, so the material that you can see here, the particular wedge shapes. Which one is it? Great, thank you. So you can see here the typical wedge shape on that side. Compared to CT angio with our typical VQ scan, the diagnostic accuracy is higher and the inter-observer variability is actually lower using dual energy CT, which is kind of interesting. This is really all emerging data. Using a pulmonary blood volume iodine map for acute PE, you can also identify findings which you typically can't see with a normal CT. Here you can see normal lung, whereas you can see here the flow defect in the pulmonary blood volume. Here you can see the infarct, and you can see the difference of the size of the infarct when you're using a dual energy CT. Dual energy CT blood volume maps can usually show more flow defects because a regular CT scan only shows obstruction at the level of the distal arteries, but the dual energy CT pulmonary blood volume maps can actually show distal, segmental, and subsegmental emboli. It also shows the effects of pleural systemic shunts. In this example, you can see, and I'll run through several slides here, the initial review of VQ scan showed no obvious emboli. This patient was sent in with suspected PE. The radiologist, however, decided to use dual energy CT, and here's the two peripheral flow defects that you can see right here, one on the bottom and one up here. And so having seen this, the radiologist went back to the CAT scan and saw this finding, which they didn't see before, where they see the obstructed vessel, at least for the bottom part. So it really enhances the ability of the radiologist to see this information. And if you really have a high index of suspicion for PE and it's not observed, you can actually ask for these scans because they're, and I'll show you how it's done in a minute, they can actually be reconstructed. What are the clinical implications of some of the flow defects? As the number of flow defects is greater, they correlate with both severity of right heart failure and mortality. In this next example, you can see this is a CTPE on this side, showing the enlargement of the right ventricle and the moving of the ventricular septum, a shift. And the dual energy CT, you can see the multiple infarcts that caused this change, which were not seen, by the way, with regular CT scan. There's a differential diagnosis to these flow defects. They can be caused by bronchial obstruction, bronchiectasis, emphysema, some vascular obstruction, and also by some artifacts, so your radiologist will need to know their stuff. In this example, you can see two flow defects, both at the top and at the bottom. However, in a regular CT scan, you can see here that while the anterior flow defect was really a flow defect, the bottom one was caused by bronchiectatic findings. So it's very important to correlate the two scans. While you're looking at one, you need to look at the other in order to understand what you're actually seeing. There are other reasons. Here's another example of a tumor that caused obstruction of the vessel, and you can see the hypoperfusion of the whole lung here in dual energy. I'm sorry that my hand is shaking a little bit because the angle is a bit odd. And here you can see on the other side, emphysema, with the diffuse findings on dual energy CT in both lungs related to the bronchiectatic disease. In chronic PE, pulmonary blood volume maps can actually show findings that are typical, morphological, vascular findings that are typical of chronic disease but not acute. So if you have suspicion that the PE is not an acute PE, you would actually look at this finding. And here you can see all these multiple small little vessels, this one here, the one up there, that one, that are typical findings of a chronic PE. You can actually see the findings within the vessels saying that there's a problem with the vessels. Compared to VQ imaging, which is the gold standard, for chronic PE, dual energy mixed morphological and functional data has a sensitivity of 97% and specificity of 86%, and more defects are seen, just like in acute PE. What about COVID-19? I just want you to keep this image for a moment because I'll be back to that with 2 slides at the end. We observed, and this was very striking to us, that the findings in dual energy CT seem to be actually less emphasized in some of the patients than the parenchymal lung injury that we saw in regular CAT scans. So the explanation for that will come in a minute. Now, what else can we do with dual energy CT? And this is really where the science fiction comes in. Post-processing can be done to the image, to the iodine maps with what is called virtual monoenergetic imaging and virtual non-contrast. So I'll give you several examples of these methods, but before a brief explanation, virtual non-contrast, you can actually take the images, erase the iodine from the image, and then look at it again. And in virtual monoenergetic imaging, you can focus on a specific wavelength, break down that specific wavelength to focus on a specific finding, and then you can either accentuate it or erase it. So here's how it can be used. This is an example of an ICU patient with chest pain. CT with contrast PE protocol, as you can see here, showed the pulmonary artery. There was no finding there. There was no PE. But the radiologist did notice that the aorta seemed dilated. So what he did was he used what is called virtual monoenergetic imaging to focus on the aorta, despite the fact that there was very little radiographic material in it. And here you can see within the aorta two colors right here. And that made him suspect that there may be a double lumen in there. So what he did was color-coded mapping. Again, this is all done with dual energy. He did it a color-coded mapping, and you can see here that on this side there is more contrast than on this side. The green is the contrast, and that made us believe that this part, the left side, the green part, is the true aorta, and the right side is the dissection. Then we did a protocol for aortic angiography, which was done for surgery because now we had the diagnosis, and you can actually see here the dissection. So in fact, we didn't have to take the patient back once that suspicion had arisen, because just using the dual energy methods, the radiologist could actually do all of this work, and the patient was prepared pre-surgery, and the last imaging was done just pre-surgery. So that spared that patient a lot of iodine and running back and forth. The next one is diagnosis of post-surgical esophageal leak. Here we had a patient with a mediastinal drain outside the esophagus after esophageal surgery. We gave contrast per os, and we saw contrast within the drain. For those of you that are not familiar, this is the drain. What you see here highlighted in white is just that line that we have along the drain to just know where it is in regular chest x-rays. And then once that was done, it was clear that there is iodine in it because iodine is dyed in red in this specific wavelength or energy length. And then what the radiologist did was basically erase the iodine from the picture. And then we could see that the material within the drain was actually coming from, was actually leakage and not what had been swallowed from above. So that deconfounded, if you wish, and allowed us to understand that this patient has a leak and probably needs to go back to surgery. Here's another example, the same example, where the leak was actually observed in the pleural space, which you can see it in red, and it's much more obvious, I think, than in the regular CT. Third example is a bleeding ulcer. So because blood has a high content of iodine, you can simply erase new blood if you want, and that way you can see the leak. Just you can see a leak if it's there. Here the differential diagnosis was with leakage. The radiologist found this finding outside the gastric area. We didn't know if it was leakage or bleeding. The patient, in the second imaging, it was highlighted in red, so it was obvious that there's iodine in it. And then using virtual non-contrast, you can see that it disappeared, and although the effect on the fat remained, that the blood disappeared, so we understood that this was hemorrhage, and a patient was taken to angio rather than to the operating room. And in this example for stroke, you can see the same concept. Many times after angiography of the brain, there's a residual contrast, and here you can see iodine staining after brain catheterization, where with virtual non-contrast it remains, but if it's acute hemorrhage, it will disappear. So that way you can differentiate between new onset bleeding or not, and know whether your patient has new onset bleeding that needs to be treated as well. And finally, I think this is my last example, if I'm not mistaken. This is sepsis after cardiac surgery, iodine mapping which was done just, because the radiologist was curious here, because at that time we didn't do enough post-cardiac surgery cases. Highlighted this finding right here. There was actually nothing that could be found in regular CT, and we were bothered by the fact that there was such a highlighting of this area, although there was a stent in that area, and we didn't know whether it's the stent that was highlighted or something else. So using this post-processing technique, basically we deleted the stent from the picture. And what you can see here is the abscess in this area that you can see in both the iodine map and the virtual monoenergetic imaging. So there was an abscess around the LAD that we wouldn't have been able to see had we not used this technique. So to summarize, post-processing of iodine maps reduces the dose of contrast media, enables salvage of information from studies with too little contrast. It's really easily incorporated in daily practice because all the images are already there. You just need to know what to ask for, and it improves detection and confidence in the diagnosis. Just 2 words about this. Returning to this COVID, what we did was we created pulmonary blood volume maps of lung aeration, and based on previous studies that determined what would be the range of Hounsfield units for ground glass opacities, consolidated lung and normal lung. We then divided the lung into several areas and looked at aeration and blood flow. And here you can see these are the 3D reconstructions of normal lungs, ARDS lungs, and lungs with COVID. And again, this is all using dual energy CT. You can see the difference visually, how it looks. I'm not going to go into it for lack of time now. We use our physicists to quantify the aerated lung area and found that for ARDS patients, the aerated area was overall higher than for COVID patients. But more interestingly, in mild COVID, we found decreased pulmonary blood volume, specifically in areas of ground glass, and that correlates with the idea of perhaps L-type lung involvement. And then we looked at this, you can see here that in ARDS and severe COVID, there's increased blood volume in the aerated lung, probably in an attempt to compensate for the lack of blood in the rest of the lungs. So with that, I'd just like to say, we can use dual energy CT for multiple indications. Once it's there, you will not be able to do without it, believe me. I mean, this is fascinating stuff for those of us in intensive care that are experiencing this. And coming soon is photon counting, but that's really the enterprise, the next generation. So I won't talk about that today. Thank you.
That was great, and thank you for your patience with us. Any questions about this exciting question?
Yeah, thank you. It was a wonderful lecture. Just two questions. You did talk about the comparison of VQ scan versus dual energy CT. Do you have comparisons of CT pulmonary CECT, contrast non-CT versus dual contrast CT?
Again, CT with?
Contrast CT, contrast non-CT.
Yes, with dual energy. Yes, yes. All the VQ scans are with contrast. The problem with contrast is that you inject at a specific time. So if you're looking for pulmonary artery, you will highlight pulmonary artery. If you're looking for the aorta, you will highlight the aorta. But when you're using dual energy CT, you can actually bring out sections of the lung that haven't been highlighted before, vascular structures that were not highlighted before. And so therefore you can spare iodine and probably identify things that you wouldn't have otherwise.
Okay, and the second thing that I noticed was in a scan that you showed that there was intimal tear of the aorta. The normal, the green area was on the right and the blue one was on the left. But when we did show the scan, the intimal tear was more towards the right.
Yeah, but
conventionally we'll think that will be the.
It's all in the same side. So the area of the green is the area with a larger amount of contrast. The area with the mixed blue and green was the area with a small amount of contrast that had managed to leak into that area at that time. But later when they saw it, they found that actually the lumen was where it looked like. So it was exactly the right. It showed the right thing.
Okay, thank you.